Baik, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Yang terhormat Dekan Fakultas Kedokteran Universitas Brawijaya yang nanti akan diwakili oleh Wakil Dekan 3 Dr. Sahdevi, kemudian Ibu Ketua Pelaksana Kegiatan Guest Lecture, Ibu Rahmadian Hanifarizani, Ibu pemateri pertama dalam kegiatan kita kali ini, Ibu Fatmawati, dan pemateri kedua yang nantinya akan datang, Prof. Gustav Dekker, serta seluruh hadirin yang berbahagia. Puji syukur kita panjatkan kehadirat Tuhan Yang Maha Esa, karena atas rahmat dan karunia-Nya kita dapat berkumpul pada hari ini dalam acara kuliah tamu dengan tema New Insight of Preeclampsia, What Midwives Need to Know. Izinkan saya, Yulia Silvani, untuk memandu jalannya acara hari ini. Sebelum kita memulai rangkaian acara, saya akan membacakan susunan acara kegiatan kita hari ini. Acara yang pertama adalah pembukaan. Acara yang kedua adalah laporan dari Ketua Pelaksana, yaitu Ibu Rahmadian Hanifarizani. Acara yang ketiga adalah pemaparan materi oleh Ibu Fatmawati. Kemudian acara yang keempat adalah sambutan oleh Wakil Dekan 3 Fakultas Kedokteran Universitas Brawijaya. Kemudian acara yang kelima adalah pemaparan materi kedua oleh Profesor Gustav Dekker. Dan acara selanjutnya adalah penutup. Sebelum kita memulai acara, marilah kita berdoa untuk membuka acara kita sesuai dengan agama dan kepercayaan masing-masing. Berdoa dipersilahkan. Berdoa dapat dicukupkan. Baik, hadirin sekalian, sebelum kita memulai rangkaian acara, marilah kita bersama-sama mendengarkan lagu kebangsaan kita Indonesia Raya. Kepada seluruh hadirin dimohon berdiri. Terima kasih. Selanjutnya marilah kita menyanyikan himne Brawijaya. Kepada seluruh hadirin dimohon tetap berdiri. Terima kasih. Hadirin dipersilahkan duduk kembali. Selanjutnya, kita akan mendengarkan laporan dari Ketua Pelaksana acara ini. Kepada Ibu Rahmadian Hanifah Rizani, kami persilahkan.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, yang saya hormati pemateri pada guest lecture hari ini Ibu Fatmawati serta para undangan yang kami banggakan. Alhamdulillahirrabbilalamin, pada pagi hari ini kita bisa berkumpul di sini dalam acara guest lecture yang merupakan rangkaian dari kegiatan 3-in-1 Departemen Kebidanan pada tahun 2024. Pada hari ini acara dihadiri oleh mahasiswa tidak hanya dari kebidanan namun juga dari program studi profesi kedokteran, dari program studi PPDS Opjin, dan juga dari Magister Manajemen Rumah Sakit. Tujuan dari kegiatan ini adalah untuk meningkatkan pengetahuan terutama terkait preeklamsi dan update-nya, dan juga untuk meningkatkan kerjasama dengan institusi luar negeri yang hari ini diwakili, yang hari ini kerjasama dengan Universitas Adelaide. Sebelumnya kita telah melaksanakan juga 3-in-1 yang bekerja sama dengan Universitas Flinders dan juga dari Adelaide, sebelumnya dengan pembicara seorang psikolog. Saya ucapkan terima kasih kepada seluruh panitia yang telah bekerja keras sehingga acara ini dapat terlaksana. Harapan saya hingga acara nanti berakhir dapat berjalan lancar dan kita bisa menambah pengetahuan, dan juga karena ada lintas profesi kita mengetahui apa saja kewenangan kita dan kerjasama apa yang bisa kita lakukan sehingga dapat memberikan pelayanan terbaik untuk pasien kita. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih kepada Ibu Rahmadian Hanifah Rizani atas laporannya. Hadirin sekalian, kita akan segera memasuki sesi pemaparan materi pertama oleh Ibu Fatmawati dengan topik Midwife Role in Preventing Preeclampsia in Malang Regency. Topik ini disampaikan oleh Ibu Fatmawati sekaligus sebagai laporan penelitian beliau yang telah dilaksanakan terkait preeklamsi dan kejadiannya di wilayah Kabupaten Malang. Kepada Ibu Fatmawati, waktu dan tempat kami persilahkan. Monggo Ibu.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semua. Om Swastiastu, Namo Buddhaya, salam kebajikan. Terima kasih pada kesempatan hari ini saya diberikan kesempatan untuk bisa berdiri untuk menyampaikan beberapa materi atau hasil dari penelitian yang sudah saya lakukan beserta dengan tim, dan mudah-mudahan kita bisa menjadi pandangan ya maupun pengalaman untuk mungkin adik-adik bidan ataupun nakes lain. Di sini juga ada pendidikan profesi dokter maupun spesialis obgyn untuk sebagai gambaran nanti ke depannya. Ya, Kita langsung ke topik aja ya. Sebelumnya saya akan menyampaikan terkait dari preeklamsi itu sendiri. Jadi preeklamsi di sini adalah suatu kondisi yang serius, di mana ada beberapa hal, terutama dulu ada trias klasik ya, tetapi sekarang bergeser menjadi tanda bahwa preeklamsi itu salah satunya adalah ada peningkatan tekanan darah, di mana tekanan darah di sini adalah dengan lebih dari 140/90 mm Hg. Nah, seringkali dengan adanya preeklamsi ini juga ada tanda lain, yaitu adanya peningkatan protein urin. Nah, protein urin ini juga merupakan suatu tanda adanya preeklamsi, di mana apabila tidak diobati maka bisa mengakibatkan komplikasi kepada ibu maupun janinnya. Di sinilah makanya pentingnya adanya screening atau deteksi resiko tinggi apakah ibu tersebut itu menderita adanya preeklamsi. Nah, di sini adalah peran seorang tenaga kesehatan, khususnya adalah seorang bidan yang bisa melakukan kolaborasi baik itu dengan dokter maupun spesialis obgyn, terutama dalam pelaksanaan asuhannya. Iya. Next. Nah, di sini saya lanjut ke definisi dari preeklamsi itu sendiri. Jadi preeklamsi merupakan hipertensi onset new, di mana ditandai tadi sudah saya jelaskan ada peningkatan tekanan darah yang lebih dari 140/90, kemudian yang kedua adanya protein urin itu pada usia kehamilan setelah 20 minggu. Nah, kemudian yang berikutnya prevalensinya ini terjadi yaitu 5-8% dari kehamilan, di mana kehamilan tersebut itu merupakan bisa penyebab dari mobilitas maupun mortalitas dari ibu hamil tersebut. Di Jawa Timur sendiri ada beberapa hal yang bisa menyebabkan terjadinya angka kematian ibu. Salah satunya ada pembagian grup ya, untuk tahun 2023 ini ada 3, yaitu grup 2, di mana hipertensi dalam kehamilan menduduki peringkat pertama. Kemudian peringkat kedua yaitu ada berikutnya yaitu perdarahan. Perdarahan ini bisa berakibat mungkin pada saat proses persalinan atau terjadinya HPP. Kemudian grup ketiga ini karena adanya perdarahan obstetrik. Perdarahan obstetrik ini bisa terjadi adanya komplikasi selama kehamilan maupun pada saat proses persalinannya. Nah, berikut ini adalah patofis terjadinya preeklamsi. Seperti yang kita ketahui bahwa preeklamsi ini belum tahu ya penyebabnya apa, atau bisa disebut dengan disease of theory. Tetapi ada beberapa hal yang bisa menyebabkan preeklamsi itu. Yang pertama adalah terjadinya faktor genetik. Faktor genetik ini mempunyai peran yang sangat tinggi, misalkan apabila keluarga dari ibu tersebut juga ada yang menderita hipertensi, nah kemungkinan bisa juga menurun kepada anak perempuannya seperti itu. Kemudian yang kedua, adanya peningkatan stres oksidatif. Nah, peningkatan stres oksidatif ini banyak hal yang bisa mengakibatkan terjadinya proses disfungsi imbutel, nanti saya jelaskan. Kemudian yang ketiga adanya proses imunologi, yaitu terjadinya antiinflamasi. Nah, beberapa hal ini yang bisa mengakibatkan perkembangan plasenta bisa menyebabkan abnormal. Nah, abnormal ini yang terjadi adalah invasi dari trofoblas yang tidak memadai, sehingga mengganggu proses dari remodeling dari plasenta itu sendiri atau arteri spiral. Nah, dengan adanya proses ini sehingga mengakibatkan juga adanya disfungsi dari endotel. Nah, apa perannya? Jadi di sini dengan adanya disfungsi endotel mengakibatkan peran cedera pada endotel itu sendiri sehingga mengakibatkan peradangan secara sistemik. Sehingga mengakibatkan regulasi dari tekanan darah yang tadinya mungkin normal bisa meningkat. Nah, faktor berikutnya yaitu faktor imunologis. Faktor imunologis ini adalah peran sistem kekebalan dari ibu itu sendiri, di mana termasuk respon imun yang abnormal terhadap antigen plasenta dan sitokin dari proinflamasi. Di sini mungkin adik-adik semuanya mungkin pernah mendengar ada TNF alfa, kemudian ada IL-6, nah itu salah satu dari inflamasi. Kemudian teori berikutnya yaitu adanya ketidakseimbangan anti-angiogenik. Jadi di sini ada proangiogenik, ada anti-angiogenik, di mana yang termasuk proangiogenik ini seperti VEGF, seperti itu, PIGF. Kemudian yang termasuk anti-angiogenik ini adalah termasuk SFLT1, seperti itu ya. Nah ini mungkin bagian-bagian yang bisa menyebabkan terjadinya preeklamsi. Nah ini pada preeklamsi itu ada peningkatan SFLT1, kemudian ada peningkatan soluble endoglin, terjadi penurunan PIGF, kemudian VEGF, dan ini juga ada faktor lain yaitu bisa diakibatkan juga kehamilan pertama. Nah, kemudian juga ada riwayat dari keluarga sebelumnya, Bu Rahma. Ya. Kemudian adanya hipertensi kronis atau kelainan pada ginjal. Obesitas itu juga memiliki peranan dan kehamilan dengan gemeli. Ini beberapa hal yang juga bisa mengakibatkan adanya regulasi atau perkembangan plasenta yang abnormal, sehingga muncullah gejala-gejala lain, yaitu ada protein urin, kemudian ada peningkatan tekanan darah, kemudian juga disertai adanya beberapa gejala lain, yaitu ada nyeri dada, pandangan kabur, dan lain-lain hal yang bisa memperberat adanya preeklamsi, sehingga kita bisa mendengar adanya sindrom HELP. Nah, berikutnya, ini ada beberapa dari sebagian penelitian saya, ini saya menggunakan dengan HUVEC di kultur, itu didapatkan ada beberapa gambaran kultur. Kalau yang A itu kultur yang terjadi pada 0 hari atau 1 jam setelah dilakukan. Itu kita lihat, yang poin A itu ada beberapa kultur atau sel endotel yang memperlihatkan dia sudah berikatan. Jadi dia sudah ada attach gitu ya, jadi saling berikatan. Kemudian kalau yang B itu bagian sel endotel yang belum berikatan. Itu bisa kita lihat bahwa beberapa sel itu sudah memperbanyak diri gitu ya dengan melekat sel satu sama lain. Kemudian bisa kita bergeser ke B, di B situ adalah sel endotel yang sudah dilakukan 3 hari. Jadi pengamatannya bisa kita lihat dalam 3 hari itu bisa kita lihat ya bahwa sel kulturnya di sini itu dia sudah mulai terlihat bentuknya pipih gitu ya, bisa kita lihat juga ada sel dari endotel inti selnya, kemudian ada membran plasma dan sitoplasmanya sudah terlihat. Nah, ini adalah sel endotel yang sudah kita lakukan pengamatan dalam 3 hari. Kemudian lanjut berikutnya, ini adalah pada saat kita melakukan pemeriksaan dengan flow sitometri, bisa kita lihat di sini flow sitometrinya itu dengan menggunakan indikator C145, di mana bisa kita lihat di sini ada pandaran ya, pandaran cahaya seperti itu ya. Itu bisa kita lihat hasilnya untuk yang kadar IL6 dan kadar TNF alfa yang tadi masuk di bagian inflamasi, bisa kita lihat di sini 97,92%. Sedangkan untuk kadar berikutnya adalah SFLT1 dan soluble endoglin, itu juga kita lihat hasilnya kurang lebih 94,96%. Nah, ini kita lihat bahwa memang terjadi peningkatan dari kadar IL6, kemudian kadar TNF alfa, SFLT1 dan kadar soluble endoglin. Nah, ini merupakan tampilan dari kultur, di mana kultur ini sudah dilakukan suatu perlakuan. Perlakuannya itu sudah diberikan plasma pada kehamilan normal dan plasma pada kehamilan dengan preeklamsi. Jadi kita lihat kalau yang atas ini adalah sudah diberikan plasma pada kehamilan yang normal. Itu bisa kita lihat bahwa bentuk dari sel endoglinnya, endotelnya, itu bisa kita lihat bentuknya pipi, kemudian juga terlihat adanya inti selnya, kemudian ada membran sitoplasmanya juga terlihat sangat bagus ya. Jadi bisa kita melihat bahwa kondisi sel endotel yang bagian A yang atas sendiri itu dia tidak ada kerusakan. Sedangkan untuk sel endotel yang bagian bawah, yang B, ini sudah diberikan perlakuan dengan diberikan plasma pada pasien preeklamsi. Di sini bisa kita lihat bahwa dia sudah mulai ada perubahan, selnya sudah rusak. Sehingga kalau kita lihat di situ terjadi seperti floating ya untuk kulturnya. Jadi dia sudah terpisah-pisah, bahkan ada beberapa sel yang intinya juga ditinggalkan atau kosong. Seperti itu. Nah, selanjutnya setelah kita sudah melihat beberapa tampilan dari kultur tersebut, kita akhirnya membuat suatu perlakuan dari sel yang sudah diberikan kultur yang plasma pada kehamilan normal maupun kultur pada yang sudah plasmanya diberikan pada pasien yang preeklamsi. Kita lakukan dengan perlakuan menggunakan antioksidan. Saat itu antioksidan yang kita berikan adalah dengan menggunakan buah delima merah gitu ya, atau pomegranat ini. Sebelum kita memberikan perlakuan, kita harus tahu dulu apa isi dari kandungan antioksidan tersebut. Jadi di dalam buah delima, di sini ada beberapa kandungan antioksidannya, yaitu ada fenolik, kemudian ada juga alkaloid masuk di dalamnya, flavonoid, kemudian ada zat tanin. Di sini adalah zat-zat kandungan yang terdapat di dalam buah delima, di mana buah delima ini apabila dipaparkan ke dalam sel tersebut, itu ada beberapa hal yang bisa terjadi, yang tadinya pada saat di teori kita sudah mendapatkan informasi bahwa ada peningkatan anti-angiogenik, kemudian juga ada peningkatan inflamasi. Kebetulan yang saya teliti dua hal tersebut. Nah, ini bisa kita lihat bahwa di dalam preeklamsi itu yang tadinya memang ada peningkatan pada plasma sel endotel yang sudah diberikan plasma normal, itu kita lihat bahwa untuk IL6-nya 51,10, kemudian TNF alfanya 2808. Tetapi pada plasma preeklamsi sel endotelnya itu terjadi peningkatan, yaitu pada IL6-nya 435, kemudian pada TNF alfanya 15.368. Nah, ini meningkat sekali. Tetapi pada saat kita berikan perlakuan dengan buah delima tersebut dengan beberapa VVM, jadi ada dosisnya adalah 14, kemudian 28 dan 56. Dari zat inflamasi di atas ini L6 dan TNF alfa, ternyata dosis yang 56 VVM itu yang paling baik, yang bisa menurunkan dari kejadian preeklamsi ini. Begitu juga untuk zat antiangiogenik, yaitu pada SFLT1 dan soluble endoglin juga sama. Setelah kita berikan paparan dengan ekstrak buah delima dengan beberapa dosis, ini ada dosis 14, kemudian ada 28 dan 56, juga sama, dosis yang 56 VVM ini juga bisa menurunkan terjadinya preeklamsi. Jadi dari dua ini bisa kita ambil kesimpulan ya, sehingga kita bisa menurunkan angka kejadian preeklamsi itu dengan pola hidup ibunya yang bisa kita kendalikan untuk lebih baik. Misalkan dengan konsumsi antioksidan, kemudian pola hidup sehat, dan jangan lupa tetap melakukan penata laksanaan yang sudah diterapi oleh dokter. Sehingga di sini peran kita harus bisa bagaimana menurunkan angka morbiditas maupun mortalitas dari ibu maupun janinnya. Nah, saya lanjut lagi di sini karena banyak sekali tenaga kesehatan yang juga hadir dalam peran penurunan angka insiden preeklamsi. Ini tidak terlepas juga adanya kolaborasi. Tetapi saya bahas dulu di sini adalah peran seorang bidan, karena bidan ini merupakan garda terdepan ya untuk dia bisa kontak dengan ibu hamil, di mana ibu hamil itu selalu pertama kali kontak itu dengan bidan, seperti itu. Kalau di daerah desa, kemudian daerah perkotaan mungkin karena sudah banyak fasilitas kesehatan sehingga kadang ibu itu langsung datang ke rumah sakit. Tetapi pertama kali yang memegang ibu hamil itu selalu bidan, seperti itu. Sehingga di sini saya jelaskan dulu peran bidan terkait upaya screening atau deteksi risiko tinggi. Yang pertama adalah melakukan asuhan antenatal care secara teratur. Jadi ada pergeseran ya, yang awalnya ANC ini 4 kali, sekarang harus 6 kali. Dan di dalam pemeriksaan antenatal care ini, bidan itu tidak sendiri. Jadi harus ada kontak dengan dokter, ibunya ini di sini, ibu hamilnya pada trimester 1 dan trimester ketiga. Kenapa kok harus kontak? Di sini ada kolaborasi ya antara bidan dengan dokter maupun nakes lain, terutama yang bagian perawat lab ya di laborat. Karena pada saat awal itu ibu hamil harus melakukan asuhan antenatal care terpadu, di mana di sana mulai dari pemeriksaan laboratorium, kemudian pemeriksaan juga terkait gigi, di sini juga ada perawat gigi maupun dokter gigi, kemudian juga ada pemeriksaan gizi, di sini bukan bidan saja tetapi juga ada dietitian untuk memeriksa gizi ibu tersebut. Jadi di sini di dalam satu kesatuan bidan juga melakukan kolaborasi dengan beberapa nakes, bukan hanya bidannya sendiri untuk melakukan ANCT. Jadi untuk ANCT secara teratur ini untuk menegakkan atau melakukan screening deteksi risiko tinggi apakah ibu memiliki hipertensi. Nah, kalau memang ada hipertensi, ini harus dilakukan pemeriksaan lanjutan, yaitu dengan melakukan pemeriksaan tes urin. Tes urin ini dilakukan untuk mengetahui protein urinnya, apakah ibu positif atau negatif. Dan selanjutnya adalah peran bidannya untuk menilai gejala-gejala. Nah, gejala-gejala yang sudah saya sampaikan tadi, bahwa kadang ibu itu tidak pernah merasakan perasaan pusing gitu ya. Pusingnya mungkin dipikir ada perubahan hormonal karena ibunya masih kondisinya trimester 1. Tetapi pusing ini berbeda, disertai dengan mungkin pandangannya kabur, ada nyeri pada bagian abdomennya, kemudian juga ada disertai walaupun sekarang bukan merupakan UDIM, bukan trias klasik untuk penegakan diagnosis hipertensi, tetapi ada juga ditandai dengan adanya udema. Nah, selanjutnya peran bidannya apa di sini? Selain dia melakukan screening, nah yang awal adalah sebelum melakukan pemeriksaan urin tadi, yang bisa dilakukan bidan adalah memantau BMI-nya atau IMT. IMT ini dia bisa memprediksi ibunya ini masuk ke dalam preeklamsia apa tidak, itu bisa dilihat dari berat badannya. Berat badan dibagi dari tinggi badan dalam meter persegi ya, dikuadratkan. Nah, apabila ibu masuk di dalam kelompok apakah dia itu masuk overweight atau obesitas, itu juga merupakan gejala awal, juga bisa menjurus ke hipertensi atau bisa mengarah ke preeklamsi. Kemudian yang selanjutnya adalah penghitungan mean artery pressure, di mana di sini kita bisa menghitung berapa sih rata-rata dari tekanan arterinya, yaitu dengan menghitung tekanan sistol ditambah diastolnya. Kemudian dibagi 2. Nah, positif itu apabila lebih dari 90 mm Hg. Nah, ini yang harus diperhatikan. Ini sebenarnya sederhana sekali screening ini. Yang berikutnya adalah rollover test. Di sini adalah dengan dia melakukan pengukuran tensi secara 2 kali dengan posisi terlentang atau posisi supin, kemudian ditensi, kemudian 5-10 menit ditensi lagi dengan posisi miring kiri. Gitu. Dan dihitung selisihnya. Yang dihitung adalah selisih diastol pada posisi miring dan posisi terlentang. Nah, positif apabila selisihnya 15-20 mm Hg. Nah, ini sudah merupakan indikasi bisa mengarah ke hipertensi bahkan ke preeklamsi. Ini yang bisa dideteksi secara awal oleh bidan khususnya maupun tenaga kesehatan. Nah, yang berikutnya adalah strategi bagaimana sih kita bisa melakukan deteksi resiko tinggi tadi. Yang pertama adalah kita melakukan penilaian resiko. Nah, penilaian resiko pada ibu hamil yang memiliki resiko tinggi ini biasanya mungkin adik-adik atau hadirin yang pada kesempatan pagi hari ini ada di sini mungkin mengenal dengan KSPR. Kalau di Jawa Timur itu hal yang selalu digunakan untuk di puskesmas biasanya. Jadi KSPR ini adalah kartu skor Puji Royati, kita bisa menilai apakah ibu tersebut itu memiliki resiko tinggi apa tidak. Kemudian dia boleh melahirkan di mana, apakah di TPMB, di bidan, ataukah di puskesmas, di rumah sakit, seperti itu. Dengan adanya instrumen ini kita bisa menilai ibu hamil tersebut memiliki resiko tinggi atau tidak. Nah, yang berikutnya adalah adanya kolaborasi. Nah, kolaborasi ini sangat penting sekali karena dengan adanya kolaborasi ini bisa menurunkan angka mortalitas maupun morbiditas dari ibu maupun neonatal. Dengan adanya tadi sudah saya informasikan sejak awal mulai dari ANC dilakukan mulai ANC trimester 1 itu sudah kontak dengan dokter, kemudian ANC berikutnya 2, 3, dan 4 itu bisa dilakukan dengan bidan, tetapi pada ANC 5 dan yang ke-6 itu harus dengan dokter lagi dan juga nakes lain untuk pemeriksaan laboratoriumnya. Nah, dengan adanya kolaborasi yang komprehensif ini bisa menurunkan angka risiko tinggi pada ibu hamil. Nah, yang selanjutnya yang paling penting adalah penggunaan teknologi. penggunaan teknologi itu sangat berperan penting sekali ternyata untuk penurunan angka risiko tinggi pada ibu hamil. Dan kebetulan untuk di kami, di pendidikan profesi itu juga ada pendukung untuk teknologi yang bisa digunakan oleh mahasiswa untuk menilai risiko tinggi, maupun saat itu kader dan tenaga kesehatan yang ada di lingkup desa binaan kami. Saya lanjutkan, untuk kenapa sih di wilayah Kabupaten Malang itu tetap menjadi fokus kami, karena desa binaan kami salah satunya juga ada di Kabupaten Malang, karena Kabupaten Malang itu ternyata di Jawa Timur itu angka kematian ibunya itu sangat tinggi, menduduki peringkat kedua setelah Jember. Jadi di sini makanya kita ada desa binaan di mana di sana kita juga sudah memasukkan teknologi yang bisa digunakan untuk menilai risiko tinggi pada ibu hamil sampai ke pembinaan kadernya, sampai ke bidannya. Dan alhamdulillah kami di kebidanan ini juga merupakan bagian dari Center of Excellence di Indonesia, di mana diharapkan dengan adanya pendidikan, implementasi penelitian, pengabdian masyarakat terintegrasi di sana, sehingga itu nanti menjadi proses pembelajaran di tingkat pendidikan. Nah, saya lanjut kembali. Nah, bisa dilihat di sini bahwa cakupan dari kesehatan ibu terutama bisa kita lihat angka kematian terutama di Kabupaten Malang itu pada tahun 2002, ini data dari profil kesehatan Kabupaten 2003. Itu pada tahun 2021 ini sangat tinggi, tetapi pada tahun 2022 ini terjadi penurunan yang signifikan. Nah, setelah diteliti ternyata penurunan angka kematian ini juga tidak lepas dari peran seorang tenaga kesehatan, di mana di sana sudah dilakukan suatu identifikasi, dilakukan screening, kira-kira apa yang bisa menurunkan angka kematian maupun angka kesakitan pada ibu maupun neonatal. Nah, selanjutnya apa saja sih yang bisa menyebabkan angka kematian ibu di wilayah Kabupaten Malang? Di sana ternyata yang paling tinggi itu terjadi pada ibu nifas. Ibu nifas, kemudian ibu bersalin, dan selanjutnya yang paling tinggi yaitu pada ibu hamil. Ini bisa kita lihat warna yang abu-abu di sebelah kiri saya. Nah, itu adalah angka yang tertinggi pada kematian ibu. Jadi biasanya cuma screeningnya pada hamil aja, ternyata nifasnya ini yang ternyata bisa menyumbang angka kematian ibu paling tinggi. Sehingga untuk pemantauan selain K1, K4-nya, KF ini juga sangat penting. Sehingga peran kita sebagai tenaga kesehatan tetap dilakukan follow up sampai komprehensif sampai masa nifasnya. Nah, selanjutnya adalah cakupan untuk kasus kematian pada ibu. Jadi bisa kita terlihat nih. Jadi di sini ada kasus perdarahan itu masih menduduki juga di tahun 2022. Kemudian ada hipertensi dalam kehamilan itu juga menyumbang penyebab dari angka kematian ibu. Ada infeksi, gangguan sistem peredaran darah, gangguan dari metabolik, dan penyebab lain. Penyebab lain ini dari penyakit penyerta. Mungkin ibu hamil tersebut bisa ada penyakit jantung atau penyakit penyerta lainnya yang mulai dari kehamilan sampai dia proses persalinannya. Kemudian yang selanjutnya adalah cakupan dari K1 maupun K4-nya. Bisa kita lihat bahwa cakupan K1 itu meningkat di wilayah Kabupaten Malang. Tetapi pada saat ibunya kembali, cakupan K4-nya itu rendah. Nah, jadi banyak ibu-ibu hamil itu yang tidak kembali ke tenaga kesehatan pada saat K4-nya, jadi loss seperti itu. Nah ini harus dilakukan penelitian lebih lanjut. Kenapa kok bisa terjadi penurunan pada K4-nya? Padahal K1-nya tinggi, seperti itu. Nah berikutnya ini adalah upaya dari tenaga kesehatan untuk menurunkan komplikasi dari kebidanan tersebut. Jadi tadi kenapa kok terjadi penurunan yang signifikan ya dari angka kematian ibu, di mana pada tahun 2021 itu sangat tajam banget ke tahun 2022. Karena ini peran dari tenaga kesehatan itu semakin banyak yang bisa melakukan screening atau identifikasi resiko tinggi terutama pada ibu hamil. Sehingga pada saat proses dia nifas maupun persalinannya juga bisa terdeteksi secara dini komplikasinya. Nah, ini kami juga melakukan suatu penelitian. Penelitian itu di wilayah Kabupaten Malang, terutama di Lawang. Kami mengambil dari 200 ibu hamil, di mana ibu hamil ini meliputi dari trimester 1, 2, dan 3. Di mana didapatkan pada distribusi kehamilan yang memiliki resiko tinggi, bisa kita lihat. Kalau yang warna merah itu resiko tinggi, kemudian yang warna hijau itu resiko sangat tinggi. Di mana dua kelompok resiko ini itu sebenarnya sudah sangat tinggi, tapi yang paling tinggi lagi adalah kelompok dari resiko rendah. Tetapi kita tidak boleh mengabaikan dari kelompok risiko tinggi maupun kelompok risiko sangat tinggi. Jadi dari jumlah dari 28% ini maupun 4% ini bisa menyumbang salah satu dari angka kematian ibu maupun angka morbiditas dari ibu tersebut. Ini tetap kita lakukan pemantauan. Kemudian yang berikutnya adalah berapa sih dari beberapa 200 ibu hamil ini yang memiliki resiko seperti itu. Bisa kita lihat tetap resiko tinggi maupun resiko sangat tinggi itu berada di beberapa kehamilan, mulai dari trimester 1, 2, dan 3. Ini kita identifikasi. Nah, ini ada beberapa hasil juga dari beberapa ibu hamil tersebut. Ini kita dapatkan bahwa dengan adanya IMT yang tidak normal tadi ya, yang standarnya mungkin bisa overweight atau obes, itu juga bisa menyumbangkan terjadinya resiko tinggi pada ibu hamil. Kemudian lingkar lengan atas yang kurang dari 23,5 itu juga menyumbang terjadinya resiko tinggi. Bahkan pada hasil pemeriksaan labnya kita juga melakukan identifikasi, ternyata reduksi urin maupun albumin yang positif itu sangat berpengaruh signifikan terhadap kejadian resiko tinggi pada ibu hamil. Ini yang kita dapatkan pada ibu hamil tersebut. Sehingga dengan adanya risiko tinggi ini ternyata juga menyumbang terjadinya preeklamsi. Nah, untuk terjadinya preeklamsi ini tidak terlepas adalah upaya manajemennya apa yang harus dilakukan oleh tenaga kesehatan, khususnya bidan. Bidan ini harus bisa melakukan kolaborasi. Kolaborasi terutama dalam penggunaan obat-obat yang bisa digunakan oleh ibu hamil. Ada rekomendasi dari WHO bahwa pemberian obat untuk ibu yang preeklamsi itu dengan dosis 75 mg per hari, di mana ini harus dengan pengawasan. Nah, peran bidan itu mulai di sini, jadi memberikan kesadaran akan pengelolaan obat yang aman itu bagaimana. Dan pemberian obat aspirin ini tidak boleh dikonsumsi oleh ibu hamil tersebut secara sembarangan. Jadi harus ada rekomendasi dari dokter berapa dosis yang bisa diberikan. Kalau misalkan ibu hamil tersebut itu memiliki resiko tinggi untuk terjadinya hipertensi, aspirin ini sudah bisa diberikan pada usia kehamilan kurang dari 20 minggu. atau pada usia kehamilan 16 sampai 20 minggu itu sudah bisa diberikan pada ibu hamil. Kemudian yang kedua, ada beberapa rekomendasi kalau memang ibu tersebut itu memiliki risiko sangat tinggi, kita juga bisa memberikan pendamping dari aspirin ini, yaitu bisa memberikan kalsium. Kalsium ini diberikan dengan dosis 1 gram per hari, itu yang bisa dikonsumsi oleh ibu hamil. Dan pemberian aspirin maupun kalsium ini tidak boleh diberikan pada lebih dari kehamilan usianya 36 minggu. Karena ada beberapa efek samping yang juga harus diperhatikan. Jadi harus dengan pengawasan dokter. Jadi khususnya dokter ini, dokter obgyn itu akan memberikan rekomendasi bahwa ibu yang memiliki resiko sangat tinggi ini harus konsumsi aspirin maupun kalsium ini sampai berapa lama, kemudian kita yang melakukan pengelolaan ibu tersebut itu pengawasannya baik apa enggak, itu harus kita ingatkan terus. Dan di Surabaya itu sudah dilakukan hal tersebut untuk pemberian dosis aspirin sesuai dengan WHO dengan rentan 60 sampai 150 mg per hari. Itu ternyata ini ada beberapa penelitian-penelitian juga dengan dosis tersebut itu bisa menurunkan dari resiko preeklamsi itu sampai 24%. Selain itu juga dengan adanya pemberian aspirin itu juga bisa menurunkan kejadian prematur sampai 14% dan pertumbuhan janin terhambat itu kurang lebih 20%. Itu yang bisa dilaporkan ya untuk penggunaan aspirin yang dengan rekomendasi. Jadi aspirinnya ini adalah aspirin dosis rendah atau low dosis. Nah, yang berikutnya adalah manajemen yang bisa dilakukan adalah modifikasi gaya hidup. Nah, ini gaya hidup ibu-ibu muda sekarang itu ingin makannya cepat saji gitu ya, sehingga ini juga bisa mendampak terhadap kehamilannya. Selain itu juga kita informasikan terkait dietnya, bagaimana aktivitas fisik, kemudian evaluasi dari gejala adanya perubahan maternal seperti misalkan ada pusing, disertai dengan pandangan kabur, ada sakit kepala yang hebat, itu hati-hati, harus kita informasikan. Kemudian yang penting lagi kita informasi adalah gerak janin. Nah, gerak janin ini harus kita perhatikan apabila bayinya sudah bergerak, berapa kali gerakannya dikatakan normal dalam 24 jam. Itu minimal paling tidak 10 kali gerakan dalam 24 jam. Kemudian yang paling penting adalah istirahat. Nah, istirahat ini pada ibu hamil juga harus diperhatikan. Paling tidak ibu harus istirahat siang 1 jam, kemudian malam 6 sampai 7 jam. Itu yang harus diperhatikan pada ibu hamil. Dengan adanya pola atau gaya hidup yang baik ini bisa juga meningkatkan kehamilan itu bisa berjalan dengan baik. Kemudian yang berikutnya adalah emergency care. Jadi apabila ada hal-hal risiko tinggi pada ibu hamil, jadi terutama seorang bidan ini bisa mengidentifikasi ya dan melakukan kolaborasi. Dengan biasanya kalau ada hal-hal risiko tinggi ini kita bidan diberikan wewenang untuk bisa memberikan MGSU 4. Tetapi tetap dilakukan proses rujukan. Jadi ini ada kolaborasi dengan tenaga kesehatan yang ada di rumah sakit. Yang tidak kalah pentingnya adalah keterlibatan dari masyarakat. Bagaimana kita bisa melakukan edukasi, terutama program kesadaran masyarakat. Di sini sudah terkait 4T ya, jadi jangan sampai terlambat gitu ya untuk proses perujukan. Makanya P4K-nya harus tetap jalan. Pada saat ibu hamil ini, apa yang harus dilakukan? Misalkan pemasangan stiker P4K itu sudah harus ada di tiap-tiap rumah yang ada ibu hamilnya. Sehingga kalau misalkan ada ibu hamil yang berisiko tinggi, ada hal-hal yang mengakibatkan dia ada suatu masalah, tahu siapa yang akan mengantarkan, siapa yang akan melakukan donor darah di P4K-nya tetap jalan. Dan alhamdulillah ini kemarin pada saat kita melakukan pemberdayaan masyarakat, terutama di wilayah Kabupaten Malang, wilayah Singosari dan Lawang ini, P4K-nya jalan oleh wilayah setempat tersebut. Yang berikutnya adalah kunjungan rumah, dan sekarang juga ada di rumah sakit itu sistem home care kayak gitu ya. Nah, kunjungan rumah atau perawatan di rumah ini juga sangat penting karena di sini juga bisa kita bisa mengunjungi atau memantau keadaan kesehatan ibu hamil itu secara komprehensif. Apabila ibu tersebut tidak memiliki sarana untuk bisa sampai atau akses ke fasilitas kesehatan. Sehingga apa rekomendasi untuk upaya perbaikannya di sini? Yang pertama adalah memperkuat dari layanan antenatal care. Jadi sekarang ada perubahan, jadi setiap TPMB atau tempat praktek mandiri bidan itu tidak boleh menolong dengan 2 tangan saja, tetapi sekarang dengan 6 tangan, di mana dalam satu PMB itu harus ada mungkin 2 bidan dengan 1 perawat atau 2 bidan dengan 1 dokter, seperti itu, walaupun dia hanya di fasilitas dasar. Begitu juga pada saat di puskesmas, di situ juga di kamar bersalinnya juga harus 6 tangan, jadi harus ada paling tidak 2 bidan, 1 dokter, atau 1 bidan, 1 perawat, dan 1 dokter. Itu yang wajib untuk dilakukan di setiap fasilitas kesehatan. Yang berikutnya adalah kampanye kesehatan masyarakat. Nah ini, kampanye kesehatan masyarakat ini yang paling penting terutama. Kita bisa mengedukasi masyarakat dan bahkan sudah ada kader juga, kader kesehatan, dan sekarang pemerintah juga mencanangkan TPK, tim pendamping keluarga. Jadi satu rumah itu sudah ada TPK-nya, baik itu yang mendampingi ibu hamil, kemudian yang mendampingi bayi balitanya juga. Nah, yang tidak kalah penting adalah dukungan pemerintah. Nah, dukungan pemerintah ini sangat penting sekali, terutama mengupayakan adanya kolaborasi dari semua tenaga kesehatan agar bisa memberikan akses ya, terutama sumber daya. Makanya sekarang di dalam satu puskesmas itu sudah ada juga dokter objin ya, juga mungkin sebagai pendamping atau sebagai konsultan di puskesmas. Kemudian juga ada setiap puskesmas itu sekarang sudah ada USG-nya masing-masing, baik di kota maupun di Kabupaten Malang. Itu juga sudah ada upaya untuk mendeteksi resiko tinggi pada ibu hamil, sehingga pada fasilitas tingkat dasar itu sudah bisa terpantau resiko tingginya. Nah, diharapkan apa yang berikutnya adalah future direction ya. Arah ke depannya apa? Nah, ini dengan adanya telemedicine. Nah, ini. Jadi pandemi kemarin itu sangat memberikan dampak yang luar biasa ya, dengan munculnya beberapa teknologi kesehatan, terutama telemedicine. Nah, tadi sudah saya sampaikan bahwa kami juga di pendidikan di profesi juga ada telemedicine, tetapi sifatnya sederhana, yaitu dengan aplikasi si bidan. Jadi si bidan ini merupakan berbasis telemedicine, di mana telehealth ya, di situ juga ada bidan, juga ada dokter objin sebagai konsultannya. Mungkin nanti bisa sambil diintip ya aplikasi si bidan. Nah, itu salah satu upaya kita untuk bisa melakukan edukasi di dalamnya, juga untuk screening untuk risiko tinggi pada kehamilan. Dan pasiennya juga bisa menilai kesehatannya sendiri. Saya harus kemana apabila saya masuk di risiko yang warnanya kuning atau hijau atau merah. Nah itu saya harus datang kemana, ke fasilitas mana, ataukah di TPMP, di rumah sakit, ataukah di puskesmas. Nah, yang berikutnya adalah kapasitas building ya. Di sini adalah SDM-nya yang harus kita lakukan pembekalan, terutama updating keterampilan, updating skill, ilmu pengetahuan juga, karena setiap ilmu pengetahuan itu selalu update ya, dengan melihat kondisi yang ada di lapangan maupun kasus yang ada di lapangan. Dan juga adanya advokasi dari kebijakan. Nah ini adanya perubahan undang-undang kesehatan, kemudian enggak tahu ya ganti pimpinan juga berubah lagi sistemnya. Nah ini kita harus bisa melakukan upaya adaptasi, terutama tenaga kesehatan. Nah, yang berikutnya adalah mungkin ada beberapa kesimpulan ya yang harus kita perhatikan, bahwa di sini tenaga kesehatan itu nggak bisa sendiri, bidan itu nggak bisa sendiri, dia harus bisa bekerja sama dengan semua tenaga kesehatan yang ada di masyarakat, terutama dokter, kemudian tenaga gizi, spesialis obgyn juga ada, harus dilakukan, dokter, profesi dokter, kemudian apoteker, kemudian juga ada kader ya, kader kesehatan itu juga masuk. Kemudian stakeholder lain mungkin juga dalam pihak eksternal ini ada BKKBN, itu juga berkontribusi terhadap bagaimana upaya untuk peningkatan kesehatan terutama ibu hamil. Sehingga di sini dengan adanya kolaborasi tim tersebut kita bisa menurunkan angka kematian maupun angka kesakitan baik pada ibu maupun pada bayi. Mungkin itu yang bisa saya berikan, mudah-mudahan pengalaman yang sudah saya sharingkan tadi bisa menambah pengetahuan maupun manfaat untuk semua yang hadir pada kesempatan hari ini. Mungkin saya akhiri dulu. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih kepada Ibu Fatmawati atas materinya yang sangat bermanfaat. Monggo dipersilahkan untuk menempati tempat duduk di depan. Sekarang kita memasuki ke sesi diskusi untuk materi pertama, masih ada 5 menit. Bagi para hadirin yang ingin mengajukan pertanyaan, mungkin 1 atau 2, atau mungkin bertanya terkait penelitian yang mungkin bisa dikembangkan lagi terkait preeklamsi, monggo silahkan. Monggo silahkan, apakah ada? Sudah jelas nggih? Jelas, alhamdulillah. Baik, terima kasih untuk hadirin sekalian dan terutama Ibu Fatmawati untuk pemaparan materinya yang sekali lagi sangat jelas sekali dan mungkin bisa memberikan ide bagi para hadirin sekalian yang hadir di sini untuk bisa mengembangkan lagi penelitian-penelitian terkait preeklamsi. Untuk selanjutnya kita akan menunggu kehadiran dari Wakil Dekan dan juga pemateri kedua. Monggo untuk para hadirin menikmati sajian yang telah diberikan oleh panitia. Terima kasih. Baik, selamat datang kami ucapkan kepada Prof. Gustav Dekker, our Vice Dean, Dr. Sahdevi, and Dr. Bambang Raharjo. Baiklah para hadirin sekalian, setelah ini kita akan memasuki sesi pemateri kedua, tapi sebelumnya kita akan mendengarkan sambutan dari Dr. Sahdevi. Next, we will hear the welcoming remarks from the Vice Dean of Faculty of Medicine, Universitas Brawijaya. To Dr. Sahdevi, we kindly invite you to deliver the remarks.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning everyone. The Honorable guest speaker, Professor Gustav Dekker, Head of Department of Midwifery, University Adelaide from Australia. Welcome to Malang. And good morning on our audience. It's a great pleasure to welcome you today in lecture on incredibly important and timely topic, new insight in preeclampsia, what we need to know. This session will address two critical facets of pregnancy management. Preeclampsia continue to be a significant challenge in maternal health care worldwide. As we know, it poses serious risk to both mothers and babies. We are honored to have an exceptional expert in the field as today. Is bringing a wealth experience and knowledge. We have Professor Gustav Dekker from Adelaide University, who will presenting on preeclampsia prevention in community health services. Prof. Gustav is a globally renowned expert in maternal fetal medicine, and we are extremely fortunate to have him today to share his knowledge and expertise with us. We are truly grateful for the opportunity to learn from one of the leading figures in this area. I believe that this lecture will be not only educational, but also inspiring to all of us, especially those who are involved in maternal health and obstetrics. Once again, welcome to Professor Gustav, and thank you for making the journey from Adelaide to be with us. I would also thank to our organizing committee for making this event possible. I wish everyone a fruitful and engaging session. Thank you. Good morning. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Sahdevi, for your kind and insightful remarks. Next, ladies and gentlemen, we will continue the group photo session. We invite the speakers, our Vice Dean, Dr. Bambang Raharjo, and all honored guests to come forward. Ibu Rahmadian. Monggo Ibu Rahmadian. We would like to ask Prof. Gustav Dekker willingness to accept our souvenir as our form of our appreciation.
to start? Okay.
Baik, selanjutnya sebelum mulai sesi materi, izinkan saya memperkenalkan profil singkat dari pembicara kita, Prof. Gustav Dekker. Prof. Gustav Dekker ini adalah seorang pakar terkemuka di bidang obstetri dan ginekologi, khususnya dalam studi preeklamsia dan kesehatan ibu selama kehamilan. Beliau telah berkontribusi besar dalam riset medis dengan lebih dari 20 tahun pengalaman. Saat ini, Prof. Dekker bekerja sebagai profesor di Universitas Adelaide, Australia. Beliau juga merupakan bagian dari berbagai konsorsium penelitian global seperti SCOPE yang berfokus pada kesehatan ibu dan anak. Karya-karya beliau mencakup penelitian yang sangat berpengaruh tentang faktor genetik dan klinis terkait preeklamsia, termasuk tadi terkait low dose aspirin sebagai salah satu tata laksana preeklamsia yang saat ini dilaksanakan, kemudian persalinan prematur serta kesehatan kehamilan secara umum. Prof. Dekker juga telah menerbitkan banyak artikel di jurnal-jurnal terkemuka internasional, termasuk BMG, Pediatric Research, dan Obstetric Ginekologi yang menjadi acuan penting dalam perawatan kesehatan ibu hamil di seluruh dunia. Now allow me to briefly present the conclusion about some of publication from Prof. Dekker. From so many of his publication, these studies underscore that Prof. Dekker's contribution to advancing maternal health and improving pregnancy outcomes. His work on preeclampsia, preterm birth, and genetic factor continues to inform clinical practice worldwide. Demikianlah mungkin profil singkat dari beberapa hasil penelitian dari beliau. Okay, now we will proceed with the second presentation titled Preeclampsia Prevention in Community Health Services, which will be delivered by Prof. Gustav Dekker. To Prof. Dekker, the time and place are yours.
That works. Selamat pagi. I would like to thank the University of Bavaria of inviting me again. I was talking to Dr. Bambang probably about 8 or 10 years ago for another lecture, but I'm delighted to be back in this beautiful city, in the beautiful scenery. I will talk about preeclampsia, of course. Can I get to the first slides? I'll see how this... So I was invited by Dr. Bambang to say, okay, talk about what are the real critical minimum things, because I can talk about preeclampsia for a long, long, long time, but we really want to focus on the essential things. So very much focus at the role of midwives or general practitioners, perhaps young residents. I'll see if this, where's the computer? No, where, shall I point on the computers to get it forward, or? And it's good, and I had to use the same slide yesterday in the Hawksby conference. It's good to reflect on a bit of history, the fact that there is this condition, preeclampsia, that actually was the start of antenatal care. Yeah, that's the whole antenatal care that you do as midwife, as doctors, is because there's preeclampsia and problems with growth. Yeah? Nowadays in Australia we also have Down syndrome screening. It's not happening in all countries, but antenatal care is really for timely detection of preeclampsia. And that, so I'll see if this, no, it does not walk with me. So next slide, please. And why is that? Because, as you all know, many preeclamptic patients are asymptomatic. This patient is very sick, it's easy to see, but many patients don't have major symptoms. So only by seeing them again and again and again, you will see the early signs of preeclampsia, the blood pressure, a bit of edema, perhaps concerns about growth. Yeah, can I have the next slide? Yeah? And it started all in 1952 by this publication by Hamlin. And you see on this important graph, this is the mortality from preeclampsia, eclampsia in England in the 1950s. And you see this when they started with antenatal care, after the publication that I will show you in a moment, long before there was magnesium, there was no blood pressure medication, the mortality dropped. In those years, you was, as any sign of preeclampsia, you're admitted and the baby was delivered. That's the only thing they could do. Next slide, please. So Hamlin, who was actually a doctor in Sydney, but it was part of the British Commonwealth, the British Empire, of course, was part of England. He said, I'm convinced that antenatal care is the key. That's the only way to prevent eclampsia. And we have to acknowledge that in a good healthcare system, eclampsia is technically is really preventable. Yeah? Eclampsia is preventable. Next slide. And he was a very peculiar man. He said it's obligatory. You have to go to your antenatal visit. If you don't show up, the police will knock on your door. Why are you not there for your antenatal visit? Go to the hospital. And he started the war on preeclampsia. Next slide, please. And you see here at about 1947, he started his attack on preeclampsia. On the left, you see the eclampsia. Where's my pointer? Sorry. Okay. I caused major. Yeah. I thought I had a pointer. Oh, this pointer. Yeah, this pointer. You see, is that pointer working? Not completely. But anyway, you see on the left the incidence of eclampsia. You see this huge drop when he started with obligatory antenatal care. And that's the start of what most of our work is. So that's an important task. Your proper antenatal care, really examining the patient, proper blood pressure measurement, and I'll have a challenge there in a moment for all of you, because there's often common errors. Is the key, is the cornerstone of our work. Next slide, please. In Australia, which of course is a quite wealthy country, it's rarely to see death from eclampsia or HELLP syndrome, for that matter. We do see complications, of course. The few people that do die tend to be our Australian indigenous, the Aboriginals, that don't show up for care at all. So we cannot, they might be in remote areas, no care, and there still terrible things happen. We do see complications. You get your placenta abruption, your renal failure, stroke. Interestingly, we don't see pulmonary edema, and that's something that you see in Indonesia. I know I've been going to Dr. Sutomo now for a long time, and I've seen many cases with pulmonary edema. We don't see that. And also, and I will not really spend too much time there, but if you have preeclampsia as a woman, it indicates that you are at risk for long-term cardiovascular disease. Now you get much more cardiac and metabolic complications if you're a woman with preeclampsia. So there's long-term consequences. Of course, we cannot cure preeclampsia. So if there's bad preeclampsia, the only thing you can do is deliver the baby. That's the doctor, and then we say iatrogenic. The doctor-induced preterm birth. It would be nice to have a pointer, but no. Anyway, the lower line, if you're born preterm and growth restricted, then no, it's not working anyway for me. You get a cycle that starts, that's called the fetal origins of adult disease. So the fact that your journey in the womb is not good for your growth, affects your whole life. Yeah? Next slide, please. Because I think I was told there's also some medical students here, is that correct? Or, yeah, any medical students? All midwives, apparently. But anyway, I tell this story to the medical students that every doctor should know about preeclampsia, even if you don't do obstetrics, because you might be an intensive care doctor, a neurologist, a cardiologist. In this case, this was a lady with HELP syndrome. That the HELP stands for hemolysis, so the breaking down of red blood cells, elevated liver, low platelets, and they can have liver hematomas. And you see that that's under the rib cage. And I was very happy. The baby had died because the mother was in shock. I was very happy to have a liver surgeon there to help me stop the bleeding in this patient. Next slide, please. In my hospital, we have quite a high rate of teenage pregnancies. So this was a 14-year-old girl who was pregnant. And she came to the hospital several times with a bit of a nosebleed. Now, nosebleeds are relatively common in pregnancy because of the swelling of the mucosa. But then she came in like this at about 26 weeks. Blood pressure 120/80, which they felt was normal. But if they had looked back, her booking blood pressure was 90/50. So 120/80 was actually high for her. And they finally did a platelet count, and she had extremely low platelet count. She also had HELP syndrome. And the doctors in the emergency department did not think of HELP syndrome. Next slide, please. And then a reminder that poorly managed preeclampsia, eclampsia, can still have very bad outcomes. This was a sad story of a young woman in a private hospital, and quite in contrast to a bit of the Indonesian settings, private hospitals with the maternity unit are actually very dangerous in Australia. Bad things happen there. It's much safer to have your baby in a public hospital. So this lady was in a private hospital. She was admitted close to term, about 39 weeks, with what they thought was mild preeclampsia. And they did not quickly decide to induce labor. They waited and waited, and she was 39 plus. And then she got the eclamptic seizure. And they all panicked, because in that small private hospital, the last seizure that they had seen was, whatever, years ago. So they all panicked. She got no magnesium, did not stabilize her blood pressure. They just did a crash cesarean section. And that's the worst you can do, because there was fetal distress. With eclamptic seizure, you forget about the baby. The mother needs to survive. So they did a crash cesarean section, and when the anesthetist intubates, the blood pressure goes up with about 20-25 millimeters mercury. So she probably had blood pressures diastolic of 120, and with intubation it got to the 150, and she got the intracranial hemorrhage. Beautiful baby, but she was in this very sad state after the delivery of the baby. And she went to a nursing home, and after she was on a ventilator for about 1.5 years, and then the family with the team decided to stop the ventilation. In the meantime, she has died, but I'm always allowed to use this slide by the family to highlight if you don't manage eclampsia well, you can get very bad outcomes. Next slide. If you look at, just now going back to basics, just when you talk to one of your non-midwifery or non-medical friends who's planning a baby, just ask them, what do you think is your rate of a complication? Huh? And the lay people have no idea how common this is. They would say, oh, 1 in 1,000. In a very healthy population, very healthy, you would, if you add up preeclampsia, preterm labor, and growth restriction, it's about 20%. Yeah? And of course, there is a link between preeclampsia and growth restriction, and there's also a link between preeclampsia and later preterm birth. If you have a high, I work in a very poor area of Adelaide. In our first pregnancy, about 50% of the patients will have a complication because it's a very unhealthy part of our population. Next slide, please. So this is typically textbook, about that for the previous one, textbook. This is what we see, 3 to 5% textbook. What we see in South Australia and a public hospital, we have about, and that's not because of the referral, because we have a whole catchment area. So the hospital where I work has a catchment area of about 500,000 people, and we have about 4,500 babies per year, and we have 10%, a good 10% preeclampsia. So it's quite high. Next slide, please. Okay, let's go to the definitions, and most of you will be aware, but it's good to get through it again. This is an operational diagnosis because you see a woman in the antenatal clinic and she might have just a bit of hypertension and nothing else after 20 weeks. That's gestational hypertension, but could be that that same woman 2 weeks later now develops some symptoms. So you can go from initially a working diagnosis of gestational hypertension to preeclampsia. Only after birth you can see, oh, it was really gestational hypertension. Then we have preeclampsia, and if you think of chronic hypertension, which is one of the main risk factors for preeclampsia, then you talk about superimposed preeclampsia. Yeah. Next slide, please. So gestational hypertension we try to use for the low risk spectrum of the hypertensive disorders. It's only blood pressure, nothing else. The woman is asymptomatic, the baby's growing well, and if you do laboratory tests, which you technically have to do, to rule out preeclampsia. There's nothing else, and that's blood pressure after 20 weeks. Before 20 weeks, it's chronic hypertension. Next slide, please. Then the rest is preeclampsia, so that's just hypertension with something else. An organ is involved, and we see the fetus as the placenta then as an organ. Next slide, please. Okay, give me the next slide. So it's not only blood pressure with proteinuria. If you have a woman that comes to your, as a midwife, and say, oh, I have this strange headache, which is atypical for me, with high blood pressure, your working diagnosis, number one, is this is preeclampsia. It could be that she had a bit of an argument with her husband that morning, and that caused the headache. But number one differential diagnosis is preeclampsia. Yeah? Of course, you check for proteinuria. I'll come back to that. You check the renal function, platelet count. If there will be pulmonary involvement, like Indonesia, yeah, definitely. And if a small baby, so you cannot have, it's always good for exams, etc. You cannot have gestational hypertension with a small baby together, because that is preeclampsia. Yeah? If the blood pressure goes with a small baby, you're looking at a preeclamptic patient. Yeah. So this is the well-known drawings from Netter, blood pressure. Edema and weight gain is a bit of a difficult one. Edema is not in the definition because ankle edema is so common. But when you as a midwife, and you also, I was informed, you see also you work with groups of midwives, when you have your continuity, so midwives are very well placed to say, hey, I've seen this lady a week ago, and I could see she has to take her rings off and she has facial swelling. That is an important sign. But it's not in the definition because a bit of edema on your ankles is so common. Yeah? And eclamptic are clear. Next slide, please. So blood pressure, and then don't move on now. Stick here. Don't go further, because I have to. No, you can one slide more. Yeah, one slide more. Yeah, next slide. Stay there. Yeah. So we used the Korotkov sounds. Now, Korotkov was a medical doctor in the Russian army for the battlefield. That's where the Korotkov sounds are coming from. Korotkov 1 is, of course, when you hear the sounds. Korotkov 5 is when they disappear. Korotkov 4 is probably closer to the true value, but if we all would measure one patient, we would have much more disagreement on Korotkov 4 than 5. So we use Korotkov 5. Yeah, now because I need your interaction now, because otherwise you're just sitting there and being quite relaxed. Just suppose I'm your patient now. You're the midwife or the doctor. Yeah? And you have on the bed, I'm flat on my bed, let's say 36 weeks, and my belly is even bigger than my real belly. And so I'm lying there 36 weeks, and you say, good morning, Mrs. Decker. I say, good morning, midwife. I'm flat on my back. Can you measure my blood pressure now? And I need an answer, because I need your. I know that you're listening and interacting. So can you measure? This is a common thing. And I do the same question in Adelaide. So I need an answer. Who's brave enough to give me an answer? Yeah? Don't be shy. Maternity care is a loud specialty. We are not silent. Yeah? We make noise. Yeah?
Okay.
I see a hand going up there. That lady. Yeah. Who wants to answer that? I'm
Who
Mrs.
wants to
Decker,
answer? Yeah? Okay, raise your hand, please.
Otherwise, it will be a very long presentation, because I will just stop. Yeah? No coffee break.
No coffee break. Okay, no coffee break. Okay, raise your hand.
Who's brave enough? Can you measure I'm flat on the bed. I'm on the bed. Pillow, good morning, midwife. Good morning, Mrs. Decker. And he said, I'm going to measure your blood pressure. Can you measure my blood pressure now? Simple yes or no. So our hands then, otherwise. Who's saying yes? So who's saying no? I want to see like 300 hands now. So you have to interact, otherwise it will not work, yeah?
Oke, mungkin saya bantu untuk menerjemahkan.
Can you measure my blood pressure? Yes or no? Yeah?
Seorang perempuan hamil 36 minggu, kemudian datang ke klinik, ke bidan, kemudian diminta untuk berbaring terlentang ya. Nah, pada posisi terlentang ini apakah bisa terukur dengan akurat untuk tekanan darahnya? Just say yes or no.
So the Bambang is brave, saying yes. He's just playing the field, as we say a little bit.
Yes or no?
So do you think you're in your antenatal clinic? Do you measure pressure? You have a highly pregnant patient. On the examination thing, you measure fundal height. Yeah? Can you measure her blood pressure like this? Do you measure blood pressure like this? There's a lady there. I don't know your name. All focused on you. You're correct. No. Why is that? Yeah, I think I did hear supine hypertensive syndrome. Is that correct? You talked about supine hypertensive syndrome. She's a brilliant midwife, you see. So she's...
Thank you.
And then, indeed, it's your uterus, your big pregnant uterus, that's on the vena cava that will reduce your blood pressure. So you cannot measure blood pressure then, and she might become symptomatic, and that's what we call supine hypertensive syndrome. Oh, so, okay. And what's your name? Sorry, I missed your name. So I could not hear that. Putu. Okay. Let's continue with because Putu is a very brave midwife. I said, okay, midwife Putu, that's fine. I'm going on my side. I'm going on my side. Oh, that's nice, Putu. That's very nice. A pillow here. That's actually very comfy. My uterus falls forward. So now I'm on the bed. Pillow here. Can you measure my blood pressure now? Yes, correct. But yeah. And why is that? You're spot on. You're brilliant. I'll offer you a job in Adelaide. You're correct. Why is that? Why do you have to sit up? Yeah. I think you're very close. You can never measure my blood pressure now, pregnant or non-pregnant, because the cuff is above my heart. For my shoulders, that would be probably you get a measurement that's about 15 to 20 millimeters mercury lower. Yeah. So next slide, please. So you need to be, the cuff needs to be at the level of heart, and you're spot on. So a sitting position, beautiful. Yeah? These are common errors that I also see in Adelaide. That's why I spent a bit more time there, because I see this error all the time. I see even doctors saying, oh, put her on the left side and we might get a better reading. Of course you get a better reading, because it's artificially low. Yeah? So don't make that error. Yeah? Okay, good. Thank you. You're brilliant. Yeah? Next slide, please. So that's cuff at the level of the heart. Pregnant or non-pregnant. Next slide, please. Proteinuria. Now that's a simple but also difficult topic. Is of course the fact that proteinuria was discovered. That's in patients that later on had eclampsia. That started the terminology pre-eclampsia. But how to measure proteinuria? The notorious dipstick. If you work in an area where you only have the dipstick in a remote area, yeah, use the dipstick. But don't forget that if the dipstick is saying negative, it's wrong 1 out of 3. If you get plus dipstick, that's highly relevant. So the dipstick is technically inferior method. If you work in any area where you can measure the protein with the protein to creatinine ratio, you see, we'll actually measure your protein, properly measure your protein. So it's really, where do you work, where are you going to work, is there a laboratory? If there's no laboratory, you can only use the dipstick, but it has its limitations. Next slide, please. Just on the signs and symptoms. That's a beautiful review by Professor Shakila in England. How useful are the symptoms? Next slide, please. Now, it's a bit of statistics, sorry, a bit more complicated. Oh, no, this one. Any test, if a test will be like flipping the coin, the line will be in the middle. You see this for more signs and symptoms, they don't help too much. Only that little dark spot left up is upper epigastric pain. So the signs and symptoms are not that useful. You might get 10 minutes before your eclamptic seizure, you might be asymptomatic. Next slide, please. But there is something where this is called the so-called Pierce score, the full Pierce, developed by Canadians. Because also Canada is a very big country and they have remote little places. So next slide, please. So they looked at more than 2,000 patients with preeclampsia. And 261 had a bad outcome. Abruption, eclampsia. Yeah? And 106 or 5% within 24 hours after admission. And they looked at the combinations of signs and symptoms that were the warning. And that's the younger gestational age. So if you see as midwife a blood pressure of 140/85 at 38 weeks in a woman where the booking blood pressure was 130/80, that's okay. That's pretty normal for a lady with a slightly higher blood pressure throughout. If you see 140/85 or 90 at 26 weeks, that in itself is very concerning. So gestational age is very important. If there's any sign of pulmonary involvement, you have to count the respiratory rate. Yeah? If there's increased respiratory rate, a bit of shortness of breath, and ideally, and that's interesting in the model in Indonesia between midwives and doctors and hospitals, you would have to do some minimal laboratory tests. And patients that have these problems at early gestation, increased respiratory rate, etc., a little bit lower platelet count, they need to go to tertiary center quickly because they have severe early onset preeclampsia. Next slide, please. Okay, so let's dive a bit deeper to preeclampsia. It's a syndrome with different manifestations. Some patients will come with growth restriction, some patients will come with abnormal blood results. Next slide, please. Now it gets a bit technical, but it's still, this is the, not myself per se, the progress in our understanding of preeclampsia has evolved very rapidly over the past 10 to 15 years, particularly by a group of researchers in Oxford, Professor Redman particularly. They've shown that the outer layer of the placenta, the villi, if you flip the placenta around after birth, you see that you see the structure of the placenta. The outer layer is called the syncytial trophoblast. Placental cells are trophoblasts. The outer layer is syncytial trophoblast, and that makes, if you spread it out, which you cannot do, of course, they calculate that will be about 2 soccer fields, and that's where the exchanges of oxygen, nutrients, etc. That syncytial trophoblasts are cells that have fused to make a syncytium. And just syncytium is a difficult word for fused cells. And fused cells cannot repair themselves. If I have a liver damage, my liver cells will repair itself. That syncytium cannot repair itself. It ages, like we are aging. And that's, biologists use that senescence. And when your placenta ages too fast, the outer layer, that is the last pathway to the preeclamptic syndrome. Now you have two main reasons to have this premature aging: a poor blood supply, and the blood supply to the placenta is the spiral arteries. But now, and that was always the classic story of preeclampsia. But nowadays, society has changed. If you go back, I have still a lot of old textbooks from the 19th century from the Netherlands, and I was originally from the Netherlands, where women were typically 17 to 19 years, then they had their first baby. So the normal time, biology, and I have 2 daughters, don't get me wrong, I'm happy that they were not teenage pregnancies, but a normal time to have a baby somewhere like 17, 18, 19. And when these women were young, lean, there was no fast food around, and the only way for them to get preeclampsia was a problem with the blood supply. Nowadays, women getting older, more obese, to age groups where women were never supposed to have babies anymore. Now let's look at that a bit more. Next slide, please. So the placenta, you see the blood supply, see if it works. Yeah, the blood supply through the spiral arteries. Yeah, and then the fetal circulation from the right. You see that blood chamber there, that's the intervillous space that is there at 10 weeks. Then it's developed. The villi over the villi is the syncytial trophoblast, that's 2 soccer fields. And the mother has to accept the placental cells growing into the spiral arteries. That's very strange, because these are foreign cells, because that's half the partner. So pregnancy is literally a miracle. If you would give a patient a half foreign kidney, that would not stay long there. Pregnancy just does it. So foreign cells really talk cell to cell where they go into the spiral arteries. Yeah? So there must something be very interesting with the immune system. Next slide, please. In the end, when the placenta gets sick, the outer layer, you get sick because your endothelium, that's the inner lining of the blood vessels, gets sick. And you have 1.5 kilo of endothelium as you sit here. It's a big organ. And particularly kidney, liver, and brain are most susceptible for the, let's say, preeclampsia toxin. In the past it was called toxemia. And we might go back to that terminology. Something makes the endothelial cells sick. Next slide, please. So let's look at this a bit more. In the past, on the left, when women were 17 years old, there was not like we have in Australia now, couples being together at the sexual level for years before they have a baby. You met your future partner and conceived. And there was a lot of problems with what we say maternal tolerization, because a woman needs to become accepting of her partner. And for that you need to have a lot of sex. So the idea is to have a lot of sex with your partner before you make a baby. Yeah? If you don't do that, you get this invasion will slow down. The mother's body will say, oh, you're a strange foreigner. I don't like you. This is not romantic love. This is immune love. Yeah? You'll say, I'll stop you. You cannot go in. Typically it gives growth restriction, but that can go with high blood pressure, and then you have early onset preeclampsia. Yeah? Nowadays we see that shift also in Indonesia, and I think I have some data on obesity in Indonesia in a moment. I've been coming to Indonesia now for 25 years, and in my 25 years I've seen huge shifts in society going parallel with KFC, McDonald's, Pizza Hut, or whatever, crap food, yeah, and eating too much candy and sweet stuff, and when people ask for dessert, they get this huge fountain of carbohydrates. And of course, your original nutrition was much healthier. Yeah, that's a big issue where, as healthcare workers, you have to be a role model as well. Next slide, please. So this is that, you see here, so I try it once again with the pointer on the floor somewhere. No. Anyway, I have to do it here. Hope you can hear me. You see, in that yellow space, that's the blood chamber. Oh, the pointer disappeared. Anyway, so you're in that yellow space, that's the interface space, the villi, and you see the blood vessels, the trophoblasts growing in, and in early onset preeclampsia and growth restriction, the mother's immune system saying, don't like you. Do not invade me. Yeah? Next slide, please. And that's what obstetricians and MFM people use by looking at a uterine artery Doppler. At the top, you see a normal, nice diastolic flow. And if you see that at 20 weeks, you know, oh, that patient has a lower risk for preeclampsia. If you're at 20 weeks, you get that lower flow pattern, low diastolic flow. That shows that the spiral arteries have not developed well. And then your risk for preeclampsia with growth restriction is about 6 times higher. That's why it's used as a screening. Next slide. So I already mentioned a bit about how that's what we see on the right now. We see this women just being technically not fit enough to carry a pregnancy. Because obesity is an inflammatory process. When you're obese, you're chronically inflamed. So when you tell the placenta, you are inflamed anyway, and it makes the placenta sick. If you go to McDonald's 3 times a day, you can eat yourself into food inflammation. Yeah? You can get the whole day of inflammation by having the wrong food. Yeah? And age in itself is an inflammatory process. So if you start to have your first baby at the age of 42, when you have BMI 40, that you're a sitting time bomb. Yeah? Next slide, please. So, knowing the risk factors. When you see patients, and I will go through these risk factors in more detail. First pregnancy in a relationship. And we also talk about preemie paternity, because it's the first pregnancy with that man. If for whatever reason you divorce and you get a new husband, you're back to being first pregnancy. So it's preemie paternity. Yeah? So you might have a woman that already had 5 babies, no complications, then whatever. Something happens to her husband, he dies or something else, whatever. She finds a new man, a new love in her life. She's back to the risk of a first pregnancy. Yeah, it's very important, often forgotten. I will show you slides about not having enough sex before conceiving. BMI I mentioned, high maternal age. I'll show you the effect of if the woman herself had a low birth weight. So ideally, and I would challenge the women in this audience, if you don't know your birth weight, go back to your mom and say, Mom, what was my birth weight? If your birth weight was low, you have a higher risk for pregnancy complications. I will show you some novel data on gestational weight gain, and this would be a very important thing where midwives can be very important in the care for their patients. And of course you have a series of significant medical disorders, type 1 diabetes, renal disease. But these people actually should be seen by maternal fetal medicine people because they always have a high risk. Yeah? Next slide, please. So this is, I will need to get a bit of your thinking again and see if someone else is brave to give me an answer. This is from my very close friend Pierre Robillard on the island of Guadeloupe in the Caribbean islands, and it becomes relevant. He noticed, he's a neonatologist, and he noticed that a lot of the babies that end up on his neonatal intensive care were from couples that apparently were together for a short time. That was his impression. So he did a proper study when he asked, so midwife in antenatal clinics were structured to say, ask the patient books, how long did you have regular sex with the person that got you pregnant? And you see here that if you had nice long period, 12 months, low risk of preeclampsia. If you conceive within the first few months, high risk of preeclampsia. Yeah? So a very simple message. Your body needs time to get used to his cells, and it takes some time. Yeah? And I'm not sure if I have some slides on that. Some tricks for that a woman can use to find the ideal partner. We'll see if that slide comes up. But there's something strange on this slide, and then I need your input again. There, you see the results. More sex, less preeclampsia. But there's something strange that does not fit, that appears not to fit with the information that I just told you. What is strange on this slide? Look at the two groups there. What is strange? Huh? I'm sure there will be another brave and smart midwife seeing the problem here. At least I hear a lot of soft chatting. Yeah. What is strange here? There's something strange on that slide that does not fit with what I just told you. There are two subgroups there. Huh? Well, you see the total. And with one of the subgroups, there's a problem.
Silakan adik-adik.
Sorry? Who's talking? Okay. Oh, you're talking.
Talking.
Oh, so
Okay.
you're going to give me this.
Oke, silakan adik-adik. Adakah yang mungkin bisa
What is
menyampaikan
strange on this
apa yang
slide?
aneh dari chart yang ditampilkan? Ada sesuatu yang
Who's
berbeda?
brave enough? You already got a good, beautiful example by one of your colleagues, but
Please raise your hand.
who can see the paradox here? There's something strange happening here. Yeah, I think this lady here is talking. See her, this lady here in the middle here, the third row. You're pointing to something, yeah? This lady, I don't know your name, but I see you pointing, yeah? Give it a go. It's not a student exam. Give it a go. What's strange? What did you see?
Silahkan.
That's one, two, the lady third from the
Mungkin
left.
dalam bahasa Indonesia silahkan. Nanti akan dibantu untuk menerjemahkan.
So look at this, what are the two big groups here? And one of them has a problem. Sorry that I make you sweat a little bit, but then I know that you will never forget it.
Ayo silahkan.
Yeah, someone
Mungkin
has
ada
a
yang sudah menemukan.
suggestion there? Yeah? We will give you a big applause if you come. Yeah?
Gloves.
Yeah? Oh, okay, now I think because of the time I have to spoil the little game. The multiples should not fit with what I just told you. And what's the mystery here is that you think of your Indonesian society, and I actually don't know what the divorce rate is here, but I anticipate that it's much lower than we have in Australia. In Guadeloupe, that's a woman-centric society. They say all men are egocentric, bad people, all men. So they say you only make one baby per man. Because one man will bring the ayam, the other will bring the rice, perhaps some potatoes. If you have 7 babies there, you have 7 fathers. They would say, you never make all your babies with one man. They say, are you crazy? Huh? In Guadeloupe, that would be totally... So this is the pre-me paternity. So you might be in pregnancy number 8, but that is father number 8. And if you only had 3 months of sex, you have a short sexual relationship. Yeah? So never forget that. If you have particularly if you see a woman in a new relationship for whatever reason, just think, how long were you together? Right? And you can ask in Indonesia probably when did you get married. In Australia, that's not very helpful anymore because half the people don't get married anymore. But in Indonesia, there's probably still goes, how long have you been married? If that's a short time, in a new partner, that's a risk factor. Okay, next slide. So because that was a study from Guadeloupe, small tropical island, people did not believe it. So we did a big study in Australia, New Zealand, and England, the SCOPE study, where trained research midwives asked women in their first pregnancy, how long have you been together with your partner, sexually? Yeah? Next slide, please. So that was the research at that stage. So 130 preeclamptics, and we also, because we thought of the spiral arteries, we said we're also going to look at small babies. Next slide, please. And you see that, indeed, if you have a short sexual relationship, you see more preeclampsia, and particularly here, conceiving the first time. That's a bad idea. You might be very much romantic and in love, but don't fall in love the first time you have sex. That would be a very bad idea. Yeah. So that confirms the studies from Guadeloupe. Next slide, please. We also looked at small babies. Now, you can be small for any reason. In our country, smoking or drugs or whatever. And not all are placental. So when we looked at all small babies, you see that odds ratio, as we call it, on the right top. You see that if it's significant, it should not cross 1. And you see, it just crosses 1. So that was not a strong relationship. Next slide, please. But then we say, okay, now look at the babies that are small, because this was a big research study, that we had uterine artery on all of them, small babies with abnormal uterine artery Doppler, and then you see the effect is even stronger than for preeclampsia. Yeah? Particularly if you look at conceiving the first time you have sex, big risk for growth-restricted baby. Okay, next slide, please. So one of the reasons I moved from Holland to Adelaide was this scientist, Professor Robertson, who discovered indeed that if you see the sperm cell again and again and again, your body starts to say, okay, that's must literally be a friendly man, because he's staying around, he's not going away, and you get what we call mucosal tolerance. Your inner lining of the uterus is saying, oh, that's a good match for me. On average, for an average couple, that takes about 6 months of regular intercourse to develop that tolerance. Yeah? Next slide, please. So that man there, you see, that's just a simple image. He can fall off and he kills himself, but you can almost visualize that there's a woman inside on the bed with not many clothes on, and her husband is probably just coming in the room. And he would say, is there anything, darling? Oh, no, nothing. I was just getting dressed. While he's hanging outside. Yeah? If this man got her pregnant, that would be clearly a new paternity. Yeah? And then that would be not a long time of sex before conceiving. So that's a simple image that you never forget. Preemie paternity and short sperm exposure. Good. Next slide, please. Birth weight. As I already shortly touched on, if your environment, my environment, when I was in my mother's womb, but particularly for women even stronger, if that was not a friendly environment with nutrition and oxygen, you're growth restricted, and you probably deliver preterm. That gives you a state of insulin resistance, metabolic syndrome, and that affects your whole life. So your own birth weight is your biggest cardiovascular risk factor in your life. Yeah, so know your birth weight. Next slide, please. And we could show that quite nicely. This is also from that same study. Because it was a research protocol, we really chased these women and say, go back to your mother, ask your birth weight, or we found it in the old hospital notes. So this is the mother's birth weight. It's not the baby's birth weight. This is when she was a baby. Yeah? So these are patients that are pregnant. That's their birth weight. And you see, if they have a nice birth weight, 3.5 kilos, low rate of preeclampsia. If they were born as a small baby, under 2.5 kilos, 9% preeclampsia. Yeah? So that's also important. So ideally, we're working on that in Australia, but ideally if you have a new patient booking, say, oh, by the way, Did your mother have your complication? Were you born term? Did you have a normal weight? And if you have this woman said, no, I was born at 28 weeks, 800 grams, that's a big high risk. Next slide, please. Okay, yeah, keep on the next slide again. Yes, yeah, push one more. So we have two types of preeclampsia, the classic type, the immunology-driven part, and now you can almost say our society-induced high rate of late onset preeclampsia. Next slide, please. Showing the effect of BMI. Now this becomes then very important also in Indonesia. This is from my same good friend Pierre Robillard. He works on Reunion Island. That's a small island next to Mauritius in the Indian Ocean. And they have complete population data because people, they all have to give birth on the island. Yeah? So they have all data. Next slide, please. And you see a very strong linear correlation between increasing BMI and late onset preeclampsia. Yeah? And it's now well accepted for term preeclampsia, which still can be very dangerous for the mother, is your BMI is your biggest risk factor. Yeah? So indeed, if you look at primary prevention, we have to educate the high school girls now, don't get obese. Try to prevent obesity. That would be, and I've seen the data from Dr. Sutuma Hospital on diabetes and preeclampsia, and it's just appalling, but it goes hand in hand with the obesity rate. There's the lower line, I want one slide back. Yep. There's a little bit of a trend for early onset disease. And early onset preeclampsia means delivery before 34 weeks. That's an arbitrary cutoff. Next slide, please. Maternal age is also not a good idea, of course. It's normal in our society now, but Mother Nature never thought of having a baby when you're 41, particularly not your first baby. Yeah? If you had 3 babies with the same man at, let's say, 32, 36, 37, now you're 41, you're probably all right. But it's not a good time for your first baby, and that's a big thing where lots of young women, and if I look in my department, we have 26 residents. There's not one single man, they're all women, and they all know this, and I think, but I'm in training now when to have my first baby, and that's a big dilemma. My own daughter is an intensive care doctor, and being now a proud grandfather, when she turned 30, I said, Joyce, is her name, said Joyce? It's about, and I knew that she was going to have a baby with her husband. I said, it's probably a good time to start to think about a baby. Bit of grandpaternal involvement, yeah? Next slide, please. Foot inflammation, I already mentioned, and you have a role model. Now, smoking is not an issue here, but as an Australian doctor, you're not supposed to be seen on the street smoking. If you want to smoke, if you're stupid enough, you do it at home. But same with fast food. And I actually have a little anecdote. I gave this lecture, of course, also for the medical students. And I said, so you should not be seen in McDonald's or KFC. It's a poor, wrong model. And I went from the university where I live to where, on the main road to my house, and there's a McDonald's there. And I see that same group of students that I'd just been teaching about, stopping in front of McDonald's and going in. So I followed them in, and they ordered the hamburgers, and I said, got you! So they actually complained to the dean about it. But you have to, you should, similar to, you're of course alcohol is not a big issue here. Fortunately in Indonesia that's good. Smoking is not an issue. Fast food is a big issue. And you have to think about that. Next slide, please. So we see, this is not from our patient, but we see patients like this. We have lots of patients, the BMI 50, 60, 70, and they eat appalling poor food. Next slide, please. Okay, going a bit close to the syndrome. So that placenta is unhealthy, and that makes the mother sick, her endothelial cells. Next slide, please. So for many, many, many years, researchers have been trying to see, what is that toxin? What is that toxin that is released by that unhealthy, unhappy placenta? And it was called toxemia of pregnancy. Next slide, please. And it is a bit more technical, but this is the future of preeclampsia care, and I'm sure within 5 to 10 years this will be routine in Indonesia as well. We can measure that sick placenta now. Yeah, so it's a bit technical, and if it's too complicated, then I have to give my apologies for that, but I cannot make it simpler. As you sit here, let's assume that most of you are not pregnant. It might be a wrong assumption, but let's assume most of you are not pregnant here. Your endothelial cells are happy and healthy because you make that little green dot, vascular endothelial growth factor. That keeps your endothelial cells healthy. Your blood vessels are relaxed. Yeah? When you're pregnant, you get more lipids, higher flow velocity, extra stress for the endothelium. Mother Nature helps by making that little blue bulb placental growth factor. And placental growth factor we can now easily measure. And placental growth factor goes up enormously, and that's why your blood vessels open up. And that's why we see the drop in blood pressure in pregnancy. Yeah? And your endothelial cells are still happy and healthy, and you don't get complications. In preeclampsia, particularly that early placental type where if you promote spiral arteries, your body as a woman is saying, I don't like the placenta. And that placenta produces less placental growth factor. The baby that's sitting on the left here will say, I'm not happy with the blood supply. And the baby releases this little thing on the right, and I cannot help it, these are the names, soluble fluid. And as you can see, that little circle there that binds to the little bulbs. So you're already low on placental growth factor, and with the soluble fluid you get very, very, very low. And now you get sick, because your endothelium needs enough placental growth factor to stay healthy. So endothelial cells swell up, they start to leak, the blood vessels start to constrict, and you get the disease. Next slide, please. Yeah, keep on going. Yeah, next slide. Yeah, keep on pushing a little bit more. Yeah. One push more. Yeah, good. So if you look at the blue curve, placental growth factor goes up, up, up. That's a normal pregnancy. Instantly, at about 30 weeks, it starts to decline because also normal placentas do age. They get older. So in the old days, we, in the Netherlands, particularly midwives and doctors in the Netherlands, we let patients go to 42 weeks. Now that's asking for problems because the placenta will get older. The placental growth factor will go down. You see the red dots is the soluble fluid, that's that fetal factor. Close to term, in normal pregnancy, that goes up. And that's exactly what we see with blood pressure. If you see blood pressure, booking drops a little bit, and close to term, it goes back to a booking, typically. If you now look at the yellow block there, soluble fluid in preeclampsia, it's much higher, and the black box, PLGF, is much lower. So the whole ratio has changed from something that helps the circulation, that now something that damages the circulation. Next slide, please. And just to, because this is current obstetrical care in big part of the world now, and I'm pretty sure it is already being used by some private doctors in their clinics here. So this is where we are now, and the future just around the corner, where we can measure this in the blood. So if you see, as a midwife, you read something, oh, placental biomarkers, please read about it, because that's the future of your management, yeah? Next slide, please. And particularly if the ratio is good and the magical cutoff is 38, you're saying, and you might have that patient, and it's a beautiful test. We've been working now with it for about 4 years. You might have that woman that, let's say, she comes to your clinic at 28 weeks, and oh, your blood pressure a little bit up. Not really hypertensive, but much higher than I would expect. At 28 weeks, you should be low. So okay, let's do this ratio on you. If her blood pressure is normal, if her ratio is normal, you can say, just stay with the midwives. If her ratio is increasing, you are developing a problem. So one simple test really helps us here. Yeah, okay, prevention, okay. Okay, let's talk about prevention, and that leads us from primary prevention to tertiary. Primary prevention is preventing the occurrence of a disease, yeah, like vaccinations. Yeah. Let's start with primary prevention. Next slide, please. Can you prevent preeclampsia? Technically, the answer is yes. If you don't get pregnant, you don't get preeclampsia. Next slide, please. So that's condom. Actually, condom use, I should change that slide. If you always use condoms before you have a baby, it's not a good idea, because your body does not have contact with the sperm cells. Yeah. But yeah. Next slide, please. Having enough sex with your partner up to 6 months, and yeah, that's a slide. So there's been beautiful studies done by this Swiss couple, Fury and Fury, and they could demonstrate, it's a very lengthy study because they could only test a woman at the time of her ovulation. They had this, I'll tell you, this interesting study. They had a couple of 100 women at the time of ovulation, so it took a long time to do it, and they were given T-shirts from young guys that had been running around a soccer field till they were nicely sweaty. And then a woman, individual woman at time of ovulation had to say, oh, that's a nice smelling T-shirt, sweaty T-shirt. And other T-shirts they did not like. And it turned out that at time of ovulation, many women are more sensed, and mammals use this all the time, to say, oh, that's a good immune match. So if you want to make a baby and you ovulate, you say to your husband, okay, just start to run around the soccer field a few times, and then I'll smell under your armpit. Yeah, that's a practical tip. Next slide. Secondary prevention, and it gets bit more basic now. Aspirin. Aspirin is blocks two products from the platelet and leaves the endothelium intact. Next slide, please. And that's a bit technical, but it has to be low-dose aspirin, about 100 milligram in, it's called Aspilet here, I think. That's about 81 milligrams here. For most Indonesian women with your weight, 81 is probably a pretty good dose. If you look at a big woman, you might say, okay, I might give you 2 tablets. Yeah? And you have to do it started before 16 weeks and take the aspirin in the evening. Yeah, next slide, please. Calcium, and that's probably all standard knowledge this. Calcium supplementation works if you have a country with a low calcium intake. And Indonesia is actually a relatively low calcium intake country. Like my home country, the Netherlands, pregnant women would drink 1 liter of milk per day, easily, or a big can of yogurt. In Indonesia, it's not always the same. So calcium will not do harm, 1 gram to 1.5 gram of calcium. Next slide, please. Let's look at Indonesia for a moment. These are UNICEF data. Look at this slide. Yeah, this is, it's hard to see from here. Yeah, 2013 to 18. Yeah, 5 years interval. Look at this massive increase of overweight and obesity. And in what group is that? People that are 18 years old. That's 2018. These are your current patients. Yeah. So there's this massive shift in BMI to very high range. If you look at 18-year-olds, up to 30% in 2018, and it only got worse, have a weight issue. Next slide. And where's the worst is with urban women. Yeah? You see women are doing worse than men, and the urban women are urban, rural. The urban women is the biggest issue. Yeah? So we really have to look at your own dietary pattern and stay as lean as you can be. And you actively have to tell your patients, you're not going to McDonald's anymore, KFC, or what out. It's toxic food. You eat yourself into inflammation. Next slide, please. And this, if you're interested, but this is all, they looked at data for the whole big regions of Indonesia. Next slide, please. And there is then a very important message. It's a bit of complicated slides, I'll talk you through, because this is very important, particularly from a midwife perspective, where you have a trustworthy bond with your patient. She will listen to you, because you're her midwife, on weight gain. Let's look at this. Yeah, next slide, please. So I did a lot of work with this friend Pierre Robillard, and we realized that if you look at birth weight, it's what we call a normal distribution. It's what we call a Gaussian curve. In a normal birth weight, you should have 10% big LGA, 10% small SGA. That's what the normal distribution. That actually only happens in women with a normal BMI. Because the big women make more big babies. And the tiny ladies, I remember I had a patient last week before I left that, she had a booking weight of 33 kilos. That's very low. A lovely lady from Malaysia, yeah. Next slide, please. And there is that, but there's interaction with weight gain. So bear with me. The blue box is the now 10-year-old recommendation from the Institute of Medicine. That WHO support, it became like really the guideline. And for a lean woman, they're saying below 80.5, the blue box was saying somewhere 12 to 18 kilos. Now we looked at this huge data set from Reunion Island, and we could show for that woman to get a normal birth weight distribution, they should probably more gain towards 20 kilos. So they should really, if you see that small woman, you say you really need to eat significantly healthy food, vegetables, proteins, yeah, healthy fats to get that weight gain. Next slide, please. For normal weight, 18.5 to 24, we were in agreement with the old guidelines. Next slide, please. And that's overweight, we also had agreement. However, next slide, obesity, more than 30, the blue box is saying, oh, you have to gain 5 to 9 kilos. When we could clearly demonstrate it probably should be somewhere between 0 to 4 kilos. So much lower. If you tell the patient gain 10 kilos, it's not good. Yeah? Next slide is this one. Yeah. You see for the very big women, the lines did not match because they were rare in Reunion Island. But clearly, it was saying these women, if you're BMI 40, you should lose weight. So you're now pregnant, now you're going to eat healthy. I will assist you, I'm your midwife, listen to me. Yeah? You have to lose weight. Yeah? Next slide, please. And we did some mathematics. And this is actually a mathematical, it's a linear line, which actually makes the point that this is very physiologically important. So the optimal gestational weight gain is minus 1.2, and you can write it down. Of course, you can, for every individual patient, you can say, oh, your BMI is this and this. This is your weight gain that we're going to achieve. Minus 1.2 times BMI plus 42. Yeah? So if you take a BMI 40, minus 1.2 is minus 48. plus 42 is you have to lose up to 6 kilos. Yeah? So you can calculate a woman's individual optimal weight gain. And as midwives, you're ideally placed, particularly in the obese woman, say, okay, we have to think about your nutrition and spend time there. Next slide, please. And this helps you to get good birth weights, but also to reduce the rate of preeclampsia. Next slide, please. So it's the same formula. Next slide. So we had looked at the whole population. On the left top corner, for non-obese women, it did not make that much of an impact. If they did not increase weight enough, they got small babies. But the moment you go to overweight, you see that odds ratio there, right top, you already halve your rate for preeclampsia if you have an optimal weight gain. Yeah? And the lower left is 0.44 and obesity 0.33. So you really, if you can work with your patients, and that does not work by saying, oh, don't increase your weight too much. This is where the continuity of care, so important in midwifery, we are much better placed than we are as MFM people. You work with the patient the whole pregnancy through, say, listen, this was your BMI, this is your weight gain that we're going to work towards. And you help her to reduce the rate for term preeclampsia. Very important. Next slide. Finish off with the last bits. It's just treatment. More for medical doctors per se. But it's good to realize that what if we see a patient with preeclampsia, what's the only thing we can do? Drop the blood pressure for maternal safety. But it's actually a risk for the baby. Next slide, please. The high blood pressure is there because the baby makes the blood pressure, because the baby wants to see perfusion. The babies love high blood pressure. It's just bad for the mother. And so that's what we call a genetic conflict. The babies cannot cope with a patient in shock. They quickly die. High blood pressure is fine for a baby, not for the mother. Next slide. But that's all. This is standard preeclampsia care. High index of suspicion is the high-risk patient. Eventually, when you think this could well be preeclampsia, you cannot escape laboratory test. And I would be interested to hear from you how you do that as a midwife. Do you do it with a GP or a laboratory? And you cannot at some stage, if you say, yeah, you have 140/90, you have to do laboratory tests to see if she has preeclampsia. Term disease is quite easy. Get that baby delivered. So it does not pay. I have good trials there. Preeclampsia at about 37 weeks, deliver that patient. Not a cesarean section, by the way. Preeclampsia does not need cesarean section. Only fetal distress needs it. Just induction of labor. Next slide, please. Always treat severe hypertension for brain, heart, and lungs. Next slide. This is a very standard textbook thing, but just a couple of points. We have lots of medications. And that if you see lots of medication for disease, that means there's no ideal medication. If there was an ideal medication, we would all use the ideal medication. So they all have side effects. Yeah? I personally stay away from hydralazine, where I trained in Leiden in the Netherlands. We were encouraged to use medication on ourselves, and I absolutely got the worst headache in my life after IV shot of hydralazine. And that's very unpleasant, but it's also difficult because now that patient that you gave hydralazine starts to complain about a terrible headache, and now it's your dilemma to say, is that now your preeclampsia or the hydralazine? So I would say stay away from it. Nifedipine, nicardipine are beautiful agents, labetalol. Metal-dopa is for chronic hypertension. If you have a patient with 160/110, clearly this is seen by them, the doctors, but that metal-dopa is not for that patient. Next slide, please. And just a bit of a finishing off slide. So the whole balance of, are we going to deliver or not deliver the patients? We have good data now from particularly Dr. Sutumo, I know quite well. where Indonesia can do what we call expectant management, but you need a tertiary center with access to adult ICU, staff that goes with it, yeah? You need to have a good, it would be silly to do expectant management if you see decelerations on the CTG, obvious. And you go for delivery with more advanced gestations, any sign of fetal distress, absent flow, and end organ damage. So it's a very, broadly speaking, we, the high-risk obstetricians, MFM people, will certainly try to get at least 34 weeks if the baby's condition would allow it. Yeah, but these are, of course, outside the direct care of midwives. But just to finish off, next slide. To make you aware that if you have cerebral involvement, it's not always a seizure. This was a teenager with preeclampsia, and she had cortical blindness. So you can have other manifestations than seizures. And I think that's the last slide, the next one. Yeah, eclampsia, that's the last one. Eclampsia is a medical emergency. And that is, the first thing is resuscitation. Keep the airways free. Get whatever help you can get. Yeah, of the most experienced people. Magnesium to prevent the next seizure. Drop the blood pressure. Do not look at the baby. If the baby dies, that's very, very sad. But you want to have a mother surviving. And the mother's health is way more important than the baby's health. Yeah. Next slide, and that's the last one, I think. Yeah, so it's a beautiful specialty, midwifery and obstetrics. I always tell the medical students, you look after the best part of humanity, women. Thank you very much. Yeah.
Thank you, Prof. Dekker, for such an enlightening presentation. Baik, hadirin sekalian, we are opening the discussion session for the second presentation. Please raise your hand if you have any questions. Okay. Okay.
And asking questions is a good thing. That's,
Okay,
don't be shy. I get in a state of acute depression if you don't ask me questions. I'm going to cry outside. Yeah?
Ayo silahkan bertanya. Oke.
Thank you for the great presentation. I want to ask, I heard from your lecture that preeclampsia may be asymptomatic. Of course, that will be dangerous if we can diagnose asymptomatic preeclampsia. So, how do we diagnose asymptomatic preeclampsia? Thank you.
Yeah, it's a very good question. Asymptomatic, I mean with that patient will not spontaneously come to you. If you have a patient with appendix, she will come to you with inflammation because she has pain. A ruptured ectopic, she will come to you. We need to have antenatal care, and you say, oh, you feel very healthy, you still have to come because I have to measure blood pressure. I have to look at to see if you're gaining weight too fast, is you grow. So we have to actively seek the signs, but she's asymptomatic. There's a difference between signs and symptoms. She will feel fine, but the antenatal care is there to detect the change in blood pressure as a simple screening. And so you have to know the normal blood pressure range. Booking, second trimester you go down, and you stay down to about 28, 30 weeks, and it's very slowly, close to term, you go back to booking blood pressure. So if you see a young woman that has 120/85 at 24 weeks, that's very high. She should not have a blood pressure at that young gestation. She might have chronic hypertension, and then you know that she has chronic hypertension. Yeah? So you look at, don't wait for her to become 140/90. You have to look at the trends. You have multiple observations of blood pressure. Yeah? Okay? That's a good question.
Is that clear? Okay, anyone else? Please your hand if you
Yeah,
have
that's
any
right.
question. Okay.
Good. Oh, you make me very happy. You make my day.
Okay, so thank you for the opportunity and thank you for the very insightful lecture, Professor Dekker. My name is Naila and I'm a midwifery student on my third year here in Brawijaya University. So I have a question for you. In one of your explanation about the high risk factor of preeclampsia is the increase of BMI. In which case would the risk be higher in women with high BMI even before pregnancy, or in the case where a pregnant woman who used to have normal weight but can't control their cravings and then they gain significant weight to almost 20 to 30 kilograms during pregnancy, which would cause them to become obese for their normal weight? Because from my own observation from pregnant women around me, they tend to have lots of cravings, especially during the second and third trimester of pregnancy. Even sometimes are encouraged to eat everything during their pregnancy. So do you have a further explanation in which case it would be a higher risk? Thank you.
Very good question. Very good question. And all the data, the big databases are on booking BMI. If that would be a very lean woman to start with, let's say a woman at 45 kilos, if she would say, oh, I'm gaining so much weight, I say, okay, your blood pressure is fine. That's probably, and you can go and let her go to 20, 22 kilos. Don't allow that in a woman that has a BMI of 38. So we see, as I just showed, controlling gestational weight gain is actually part of reducing the risk. So if you flip your answer around, if you eat uncontrolled, and some women can say, oh, eat for 2 now. No, you're not eating for 2. you have to eat healthier. So I would answer that massive gestational weight gain in most women actually will increase their risk for preeclampsia, yeah. Particularly if they already start to be obese. Yeah? If they start high, even it's only BMI of 30, that's not a woman that should gain too much. Which I think is, you're beautifully placed as midwife to say, listen, I'm going to work with you. I know you have the cravings. What are we going to do? And instead of having a sweet snack or carbohydrates or chocolate, say, okay, if you're very picky, have something proteins. Just low fat, low proteins, low carbohydrates. In the end, you can only try to motivate them. Yeah, that's always, patients come to you for your expertise and your care. We cannot force them, but you can, of course, softly increase the pressure there, particularly as a midwife. They'll probably listen much better to a midwife that they know and trust than to an MFM person that they only see once. We do our little technical thing, but they say, oh, I'll talk with my midwife about my lifestyle. So I think that's, so I would say both, and they interact. The BMI of gestational weight gain interact. You can be more relaxed with a very lean girl, and be very strict with the obese girls, yeah, or women, sorry. Very good question.
Okay, thank you, Naila. Maybe another 1 or 2 questions more. Okay.
So while you're thinking of questions, don't forget the, and I think I will be okay for midwives advising to low-dose aspirin, but start timely. I typically would be a patient that had, she might say, okay, my mother has preeclampsia, my sister has preeclampsia, that gives a risk. I did not specifically, I should have added that, by the way, that her risk is about 7 times higher. So that gives us a 30% risk of preeclampsia. You say, okay, you start on low-dose aspirin, but start before 16 weeks. Yeah? And tell them every evening you take your low-dose aspirin tablet, yeah?
Okay, thank you, Professor, for your presentation. Well, I have heard from your, presentation, but semen exposure is actually can lower uh, the risk for
Yep.
developing preeclampsia, right? Well, but if, for example, if a woman with her partner is, if I can say is lucky, they get a fast conception because they don't use any barrier type
Mm-hmm.
of contraception. Well, are you suggesting that sure uh, any any women who don't want to get pregnant fast, but they don't use
Use
any barrier
contraception.
trace,
Yeah.
yeah, not barrier
Yeah.
type like
Yeah.
contraception, shall use
I'm not
any
sure where you're
type.
sitting, but oh, yeah, good, good, good. Yeah.
Yes. Are you suggesting that any pregnant women who don't want to get pregnant should get any type of contraception, like maybe
Yeah,
oral
right,
contraception
yeah,
or?
that's a very good question. You might have that enthusiastic young couple just married, and if you happen to meet them as a GP, for instance, if she comes in for a pap smear or whatever, and you know that she got just married, and say, okay, congratulations with your marriage, and you can say, listen, it's actually better for you as a couple if you don't try to conceive in the coming 6 months, assuming that they did not have premarital sex, because that's, of course, different in society to society. And then the question, okay, shall I use? I said, I don't want to be on the pill. And the woman said, no, that makes sense. Condoms are not a good idea. And then you might say, okay, what you could do, you might explain them on the menstrual cycle, where ovulation is, and you talk a little bit of natural contraceptive methods. If in that scenario, that would be, yes, there's a risk of failure, but that's relatively low. It's okay, don't have sex, and you explain them when ovulation is. You can have safe sex up to day 8, 9, and then you can have safe sex again from day 20. But in between, probably abstain from vaginal intercourse. And if you're able to have that type of discussion with your patients or your clients, clearly they are probably going to be quite compliant, and they're probably they understand the issues, they're more educated. The problem is with patients that are poorly educated, which we also have in Australia, and they probably never listen to our advices, and in reality they never, when I look at my practice or hospital, I think about 50% of the pregnancies were not even planned. I'm not saying unwanted, but they were not planned, and there's nothing we can do there. But ideally, the setting there is indeed a general practitioner who happens to know that, to see that young woman, and he knows that she actually recently got married, etc. That's good to proactively start the discussion. It's actually better to not fall pregnant the coming 6 months. But you can only advise them. And I can fully understand that the woman is saying, I'm not going now to start to be on the pill for 6 months. I would also not do that. So you can talk about other ways to avoid that pregnancy in the first 6 months. Yeah. Otherwise, I did not specifically mention that. So if you look at fertility patients with donor inseminations, they're automatically high risk because they only had perhaps 1 or 2 inseminations. So donor inseminations are always high risk. I did not explicitly mention that, but thanks, that's a good question, yeah.
Okay, thank you. Maybe once more.
So you're all going to make no further errors with blood pressure, and perhaps you already did it correctly, but now you know what the fundamentals are, Never, never make these errors in blood pressure measurement. And I'll see them all the time in Adelaide as well. So this is not something specific you do. I see this all the time with residents and midwives. So I never forget that fundamental problem with blood pressure measurement. Yeah.
Okay.
Just if I'm because I did not stress that specifically, but I think the young men here in the audience are probably more likely to be medical students or residents.
Do you want to give
yeah.
a question?
No, not a question, but just I just mentioned that shortly. The woman that has a pregnancy complication, if you have gestational diabetes, you're on your pathway to type 2 diabetes. If you have preeclampsia, you're very much at high risk for cardiovascular morbidity. Now you could say, oh, we all get cardiovascular morbidity or cancer later in life, but we and others have good data that from your preeclamptic pregnancy to your first cardiovascular event is in the order of about 15 years. So if that's a 25-year-old woman, she might have a major cardiovascular event, angina, stroke, when she's 40. So the patient with bad preeclampsia needs proper follow-up by a physician with an interest in cardiovascular health in women. And that's also important for midwife. If you see that the patient postpartum, you say, that's not fine, that everything went well, you had bad preeclampsia, but you're healthy, your baby's healthy, congratulations. Encourage them to do breastfeeding, because that was good for their cardiovascular health. And advise them to go to GPs for further checking their cardiac and metabolic well-being. Yeah? Yep.
Okay, is that enough? Okay.
Dr. Bambang.
Dr. Bambang.
Woman with a high risk for developing preeclampsia. So the midwife can.
Yeah, so I mentioned before already. That's what should be absolutely routine in your care is, of course, your booking blood pressure, BMI. Yeah, I would say check with her how long she has been together with her partner, and check family history. Yeah, that would be the most critical factors on your initial screening. Positive family history increases your risk. And these are simple questions. If you're very dedicated midwives and say, oh, do you happen to know your birth weight? Ideally, I would like to get that into, but we are still struggling with that in Australia. But that would be the four, that would be the four risk factors. And I'm sure that Dr. Bambang also wants me to communicate that if you have a patient with known medical disorders like chronic hypertension on medication, renal disease, she's always high risk. And I'm very much pro-midwifery, and that from the Netherlands, I think that all healthy women should only see midwives, but that renal patient or with significant essential hypertension has to see high-risk obstetrician, because you don't have the laboratory checks and a fetal surveillance to look after her. And that's not a criticism, that's just reality. Yeah? And a patient with lupus, chronic renal disease, they are not your patient. And these are patients that we see as MFM. Yeah? We should basically not spend our time on healthy women. We spend the time on the women that are known to be, let's say, sick. Yeah. Okay. Thank you.
Okay.
Thank you very much. Thank you for your questions.
Thank you to Prof. Gustav Dekker and the audience for the interactive discussion. With that, we conclude today's event. Thank you to all speakers and participants to your contribution. Hadirin sekalian, demikianlah rangkaian acara kuliah tamu hari ini. Kami ucapkan terima kasih kepada seluruh pembicara dan peserta yang telah berpartisipasi. Sampai jumpa pada kesempatan berikutnya. See you at the next event, Prof. Gus. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. Para hadirin,